my friends and juniors and the big breed of residents. I wish there were more people because I would have wanted all the residents to listen to what I'm telling. We've had enough of pancreatic appendectomies. We've had enough of complications of lap chole and all that. That will make us reach what our goals are. But if it's done that they are good. Nobody bad would have reached this place. It's not possible. But we need
वीडियो नहीं आ रहा है वीडियो भी है रिकॉर्ड हो रहा है आपका भी रिकॉर्ड होगा मेरे पास लिंक होगा जो इसका नहीं यहाँ से ले लेना मेरा लेकिन ना ये रिकॉर्ड में ना वीडियो नहीं आ रहा है हो रहा है
So many of you characters in life
अच्छा ये तो ये ना ये कैसे
is super specialty, and there needs to be one extra subject that is finances. And that is what is important. Probably your degree and
किसको पहले करा रहा
scholarship and
हूँ पहले करा रहा हूँ
where other things don't matter much in the practice. When you enter in the practice, even the 100% and the first person there at the same time. And probably it matters more in the practice than in the medical college. And you need to be really financially smart, street smart. And for that, I think there should be one extra topic which needs to be taught at each and every level. I know there is one group called one probably more people would be aware of it. That's an financial platform which runs on Telegram. And it is for all athletic people. And the first thing is no commission will be paid. Everyone is direct. You buy mutual fund direct. You do everything is direct. Don't involve any intermediary in any financial transaction. And that group is having more than 50,000 doctors actually. And you can get help on that. Of course, that is my personal recommendation, but this is the one group which aim at that. That financial literacy is equally important for doctors, and don't get any ride with any other person. And thank you very much.
Sir, one very important thing which I forgot was the course fee for my MBA from which Pilani was 7 lakh rupees. And the course fee for IIM MBA, which is a hybrid course again, is 22 lakh rupees. Try doing this at any point in life, whenever you think, spend money to save money. Please do that.
Thank you, sir. This brings us to the end of session 1. Now we'll be starting with session 2. I request the chairpersons for session 2 to kindly come up on the stage. Dr. Ashok Kumar, sir. Dr. Brijender Singh, Consultant Surgical Gastroenterology, Bridge Hospital, Kanpur. Dr. Mahendra Narvaria, Chairman and Managing Director, AB Plus Specialty Hospital, Ahmedabad. Dr. Puneet Gupta, Director, Minimally Invasive Surgery, Max Super Specialty Hospital, Lucknow. Dr. Pratul Raj Gupta, Consultant, Nova Hospital, Gomti Nagar, Lucknow.
Good morning. So after the talk on financial stability and lot of finances by Dr. K.J. Singh, now we'll move from India to outside. Dr. Ritu Khare will tell us about working outside India, how it is. Dr. Ritu.
Good morning, everybody. Anuman, it's a pleasure to meet all the senior teachers and the colleagues and batchmates and now juniors also. So in the last 2 decades that I have been outside, the maximum calls that I have ever got from people from SGPGI or for my previous colleagues first, Ritu, कोई option है क्या बाहर आना चाहिए क्या बाहर या is it a worthwhile decision to consider an option outside? So when this thing came, I told Dr. Anu, let me talk on it. So well, on a serious note, most of the healthcare outside India is strongly dependent on talent from India. And whenever we are considering a decision to move abroad, it is not just about a financial decision. It's a full-on decision about migration, and it is definitely not a change in location. but a completely different professional trajectory. And especially for surgeons, if you consider the surgical training, surgical professions, surgical competency in India versus the West, it's a lot about a cultural shock and the localization. I will not go into the details of why one would want to look at the options abroad, but since we are not considering a general surgery spectrum, we are talking specifically of an MCH or a non-MCH trained gastrointestinal surgeon. One factor is that most of the super specialty people may not be interested in going to the rural areas, and they look for an infrastructure which can sustain them. And if they find that system is not able to adapt them, if you look at the West and the Middle East, they are looking for Indian talent. And there is a big vacuum where they need the Indians to come and get the employment and serve their healthcare system. So some of the reasons which I feel have been important is in a time frame within 10 years after an MS and a fellowship or an MCH is most commonly is family reasons. Sometimes that chalo chalte hain, try karke aate hain, dekhte hain. Second, teething troubles that you are not able to find a very good, well-paying job in the corporate sector, or wherever you have taken a job, you are not finding a professional satisfaction, that you look for options abroad. And some people like me, when we moved outside, कि चलो थोड़ा सा पैसा कमाते हैं, we'll earn some amount of money and come back and set up the practice back in India. But if you consider people who have already been completed almost 10 years or a decade of practice, the reasons why they are looking out is burnout, lot of work, minimum payment, a will to earn more money, a lifestyle change, and an opportunity for establishing a program or a service in need. What are the three most common options which people look for? And UK, US, Middle East. The UK people would not go after doing a GI surgeries fellowship. Most of the people after MS or maybe just after MBBS may consider the option in UK, go for a high volume setting, get a training done. But once they are trained, after say 8 to 10 years, they hit a barrier and there they find less of professional development. And there are high taxes and cultural differences for the generation next. For US, the entry is very difficult, and to repeat the surgical training, accreditation barriers, visa, green card limitations. So in all, the Middle East looks a very easy, approachable option, shorter distance to hometown, similar cultural nuances, proposed better lifestyle and financial growth. So people are more and more attracted towards the Middle East. There is a big reason where you can compare the three, but I'll summarize it how it says. Saudi Arabia to nahi, because Saudi Arabia is opening up now, but Middle East in general is often considered as a financial sprint. West is a career marathon. If you go there and you settle there. And India is always considered as the clinical foundation for both. Focusing on the scope of practice in the Middle East, nowadays, there's a great demand in the private sector for the MCA-GI surgery. Initially, the license was only for a general surgeon and there was no GI surgery as a specialty. But since 2018, they introduced GI surgery as a specialty, and MCH was the minimum basic qualification to enter that surgery. Most of us before 2018, on for me before 2000, those who had done a non-accredited fellowship or a non-MCH were not considered into that GI surgery bracket. But later on, when more and more people have been joining, they have a specialty license for gastrointestinal surgery per se. Volumes are increasing because a lot of patients were going abroad for treatment, and that abroad treatment has been cancelled, and they are now considering treatment in Middle East. Institutions want to establish a kind of a niche field where they are handling complex GI and laparoscopic cases. And most important, infrastructure is beautiful. You have everything at your hand. You want a mesh, you want a tactor, you want a robot, everything is available. If you compare the salaries and the position, the salaries are definitely higher, but position of authority may be a limitation. If you want to become a director of a service or if you want to become a head of the department, you may have more competition from the Western expats. And here is the reality check when we compare it, that the salary is determined not only by your skill set or your competence, but it is also determined by your passport, whether you're a Western qualified person who's returning from UK or a person who's returning from US. And this reverse brain drain from UK and US is very prominent in Middle East because the UK people, their pay parity is almost the same as in India, almost a little bit negative also. But in US, there is another regional bias is about kind of a discrimination against the Arabic people. So a lot of Palestinians, Egyptians, Lebanese, Syrians who have gone to US and have got beautiful qualification, 10 years experience, 20 years experience. They want to come back. And when they come back, they don't want to go to their own respective countries. So they land up in the Middle East. So we have to kind of have a stiff competition with that. Of course, it's a small area, 9 million to 11 million population with multiple centers of excellence. Government sector is very limited. Healthcare is predominantly privatized and insurance controlled. And so when it comes to insurance, there is a high network card and a low network card. And low network card, whenever they have a serious problem, anyone has a stroke, has a knee replacement, has a malignancy, needs a major GI surgery, they will make an excuse that my family is back in India, we want to go back to India. And a lot of people, where it's Kushal, a lot of people from Gujarat and Dr. Nadaria and many other people, they are actually centers of excellence which attend to the patients who are coming from the Middle East towards India to get the procedures done. So one major conflict which I would like to address, Dr. Sadiq is just gone, is what we have been discussing informally, is the differentiation of this term surgical gastroenterology, which is not recognized on a global scale. If you look at NHS and if you look at largely Australia, New Zealand, US, they have an upper GI, colorectal, FPB, and thoracic department. And there is a distinct kind of difference in the training of these departments, that upper GI person will do upper GI only, benign and malignancy both. But in UK, there is a division between benign and malignant upper GI also. Colorectal will do colorectal and he'll do all the colonoscopies and endoscopies also. HPB will do HPB and do transplant also. And thoracic will do the esophagus. So where does the surgical gastroenterologist of India, who is an MCH, fit into this patient referral pathway in the hospital? Because the hospital aligns itself to the NHS practices. Now, this is a big controversial thing. I think one of the persons may be talking, where somewhere we need to understand. The second problem is the privileges. The privileging system they follow from the US. So if you are an MCH on GI surgery and you land up in the Middle East, it is not that you will invariably get the privileges to do all the surgeries. You need to document a specific number of cases. Now, if you want to do a pouch, or if you want to do a major pancreatic or a liver resection, or if you want to do some esophageal surgery, if after landing in UAE, you have not done an adequate number of cases over the next 5 years, your privileges will be curtailed. And here is a very, very challenging aspect, is that volumes are low. And, kind of my next slide will say that indemnity is a big issue. So if you lose those numbers and if you don't have enough numbers documented on the logbook, you may lose the privileges. So de-skilling is an actual reality. And one has to be very, very careful in performing new procedures, because unless you have documented that you've been trained under a mentor for X number of procedures, you cannot do new procedures in the hospital. So indemnity, as people are mostly scared, is a problem, because complications have a profound effect on the each complication is audited. There is a peer review with external auditors. If I remember correctly, when I was in HGPGI, we used to have 2 morning sessions for pre-op audit and the post-op audit. But that was to learn from the complication for what not to do in the next case. But here, the clinical governance involved, and I have been learning all these terms of clinical governance and negligence, because NHS runs that way. So if there is a complication, then they will come to a root cause and they need to show that they have taken an action against it. And whatever action they take, they cut your privileges, they put you under supervision, or if it is like a DHA case, whether your licensing is affected, these are like kind of administrative issues. But what is the real problem is that the insurance will refuse to cover the cost of a complication. So inadvertently, either the hospital has to bear the expenses, or if you are a private surgeon somewhere, the surgeon has to bear the expenses. So having said all those negative things, it's not like such a dead end also. There is a very beautiful work-life balance. If you were to do 4 surgeries to earn an X amount of money, you do 1 surgery. You have time for yourself, you have time for your family. It's a beautiful melting pot of cultures. Your nurse is a Filipino, your assistant is a Pakistani, you have an Arabic person, you have a local, person on there, and you learn to communicate. So the disease remains the same, but how you explain to the patient, how you tell them about the complication, how you make them understand about the surgery is a very standardized learning exercise. So somewhere you need to have a trade-off between very high clinical volume and hands-on experience versus a structured training, simulation, and protocol-based procedure. As I said, de-skilling and surveillance is a proper threat. But having said that, before I come to this slide, times are changing. It's not a lost cause. I remember I've been there for 2 decades now, 22 years to be precise. I learned one thing which all my seniors have been telling me. Whatever you do your best. It may be a lap pulley, it may be a lap hernia, it may be something like a pancreatic resection, it may be a fundo, it may be something else major, whichever you can handle. And having said that, now we have completely exclusive departments. And if you look at this picture carefully, I would love to zoom this picture. 80 to 90% people in this picture are Indians. Now, Indians who have come from India, Indians who have been trained in UK, Indians who have been trained in US, but have come here. So if you look at this picture, that this is basically an Indian skill set. And it is very easy and possible to kind of establish a department, a niche practice, use your skill set to have a leadership position and perform cases, but you should be really confident and capable enough of doing that. The verdict, there is no verdict. Everyone has their own pathway, but still, if you look at today's alumni meet, there are only 2 people who have come from abroad and everybody else is from India. So that says that the mastery path remains in India and doesn't go abroad. But you can still consider the options. Life has its own pathway and you need to design and suit whatever works for you. I'm proud to be an Indian. I'm proud to be an SGPGI alumni, and I'm proud of the journey so far. So please join us anytime if you wish to. Thank you so much.
Now, is there any question session? Can we have some question here? We can have. Huh? Yes. So, because finally you have concluded that everybody decide his or her own pathway to settle after training program. So there are any young people who I think most of us are finally the pathway is the home country. But the young people, what do you advise them keeping the future prospect of money, medical legal aspect, indemnity, some socio-economic disbalance overseen in Middle East, especially in the Middle East. And also there are lots of salary disparities compared to the people trained from UK, which trained from US, and the local people. What would be your final advice to first graduate, because they are at kind of crossroad of their career? What should they do?
Sir, find the correct place and the opportunity. First thing I feel that younger people should not come abroad. we should get the proper skill set, because uh, I personally feel like that if immediately after MCH or something you go and start doing major cases, you may not land up in a complication, but you are very unsure of things, of how things are happening. And I have also had the experience of traveling people doesn't work. So what I suggest is one should gain a good skill set. But senior people, like people who have been there, done that, have their, professional satisfaction of doing a lot of work in India and are looking for a position abroad. There are positions, but one has to explore diligently, because they are not too many. People will give you false promises. Cost of living is very high. So, what looks like a very good opportunity may not be one of the best opportunity. But having said that, uh, if you feel that you get a good position and you are able to offer something which is in demand over there, like plastic surgery ho gaya, like robotic urologist ho gaya, these are some of the branches which are really needing a talent, and if you are up to it, why not? So I think that you have to explore whether your skill set is matching with the demand in that place. Work is beautiful. There is no doubt.
Thank you very much.
Huh?
Thank you, Ritu. And now I invite Dr. Ravindra Naik. I think he built the biggest health empire in the country among us. I think he has 250 beds of hospitals. He has his own newspaper as well. So we should learn from him how we can do something little better than that also.
Thank you, sir. Thank you, ma'am. First of all, thank you, Anu madam, to suggest me to deliver the lecture on how to build a healthcare empire. So basically, healthcare empire is not an infrastructure, not a stone, not a ego. It's a basically based on the trust and outcome. So we create our foundation of Sri Balaji Group on Sarve Bhavantu Sukhna, Sarve Santu Niramaya, Sarve Bhadrani Pasyantu Ma Kaschit Dukh Bhagvet. Maybe all free from illness. This build on the Vedic principle. So Chhattisgarh is newly built state. Population is approximately 35 millions, and difficult and distant the distance district, but rapidly growing, mineral rich, and many industries and public sector are there. And we have 7 set up in Chhattisgarh, that 5 in the Raipur itself, and 225 kilometers away from the Raipur, that Raigad and Korba. So this one is the healthcare empire of Balaji Group. We have 1,500 bedded super specialty NABH accredited hospital. We are the pioneer in liver transplant till yet. 70 liver transplant we have done, more than 100 kidney transplant we have done. Along with that, 350 beds ICU, and average occupancy more than 100 patients on ventilator in every day. That we are the largest in pediatric cardiac surgery, more than 2,500 till we have operated in pediatric cardiac surgery also. The second hospital just in the Raipur, 750 bed. The third hospital, it's 225 kilometers away from the Raipur. It's Raigad, basically industrial rich bed, that 300 beds. The 200 beds cancer hospital. Both are situated in the Raipur. One is the 15 kilometers away from the main center. So total of 2,950 bed hospital. Along with that, 250 medical college, 250 MBBS seat, and 100 PG seat is running in the one medical college, and second medical college 150 medical seats is upcoming. Then we have one dental college, 100 seats, second batch is going on, 2 pharmacy, 2 nursing, 2 paramedical college. Then 1,600 student capacity with 34 professional courses is running, including 4 BTech like engineering college, and 1,500 student of that school. We have one second highest temple of Lord Balaji, that 20,000 square feet temple with 77 square feet height. Along with that, Balaji Jan Kalyan Samiti Medical Foundation and Balaji Chena Blood Bank. So this empire of 2,950 beds, along with 850 MBBS student, 166 PG student, 100 dental student, and the most satisfied things for us, it's a 4,100 employees are there, staff and their family, उनकी रोजी रोटी और उनका परिवार जो है वो बालाजी से चलता है. And this empire consists of in the 122 acres of total campus. So this one is 1,500 bed first building. The second is expanded view. This view is the 1,500 along with the medical college. That 750 beds bedded hospital with proposed 150. This one is the super specialty center. This and in super specialty center, we are pioneer in liver transplant, kidney transplant, and also robotic surgery. 4 to 5 robotic surgery in a month we are regularly doing. So this 300 bed remote industrial reach industries that Raigad, the 300 bed hospital, then 200 bed cancer hospital Jora, then 200 bed cancer hospital along with the higher things, true beam, linear accelerators, CT simulator, brachytherapy, PET scan, and also these things. Then this medical college in India, only 6 medical colleges owned by the doctor. And the 5 medical college owned by the doctors with partnership. By the blessing of God and all my mentor, my teachers here from the SGPJ and all my teachers in MBBS and MS, this is the only one medical college in India run by the doctor own, without any partnership or anything. So this dental college, then nursing college, then nursing and pharmacy college, 2 nursing, 2 pharmacy. Then Balaji Blood Bank, that 11 blood bank are there. This one is the professional college and this lower one is the school. So this one is kidney transplant, liver transplant. Then the first patient in Ayushman pilot project is registered from our center. That is the pride for us. In Ayushman Bharat, the first patient registered from our hospital in the night to 2:30 a.m. So we are not taking single rupees if the baby girl is born, just to see the face, a smile of the mother face. Until yet, 1,500 baby girls are born, and lot of charitable work we are doing that. And apart from more than 30 conferences, because we have a good auditorium, so apart more than 30 conferences we have conducted, but the prestigious one is the international conference Amasikan 2023. That in our setup, that conference was done in our setup, so that is the prestigious thing for us. But the more thing is that Dr. Kapoor sir, Sikora sir, Rajan Saxena sir, along with Dr. Mahen, Dr. Rakesh, Dr. P. Balachandran, Dr. T.D. Yadav has already visited in our setup. So, and Dr. Palaniwalu sir and Dr. Pradeep Chaube also. Dr. Palaniwalu sir has operated in our setup and Dr. Pradeep Chaube sir also visited here. Some minister Amit Shah ji, Arun Jaitley ji, Rajnath Singh ji, JP Nadda, Om Prakash Mathur ji has already visited our hospital. And the four CM in the Chhattisgarh, Ajit Jogi ji has admitted 18 times in our hospital. Along with that, the Raman Singh ji, Bhupesh Baghel ji, and Vishnudev Sai ji, they all are admitted in our hospital. So in way forward, basically by the end of 2027, our aim to create 4,400 bed hospital, basically the largest hospital in the country. And this year we are waiting for DM and MCH course in seats in 13 subjects. And we have already got approval from the state and the university. So we are waiting for 62 MCH DM, including that 4 seat of surgical gastroenterology also. That all credit goes to SGPGI. Because I did my MBBS and MS from the Government Medical College, Raipur and Bhopal. So after that, I enter in the SGPGI. And under the mentorship of Kapoor sir, Sikora sir, Rajan Saxena sir, Ashok sir, Richalal madam, I excel myself in surgical skill, work ethics through rigorous exposure of higher and complicated cases. And this one is the initial step to help me to build my strong foundation of my personal excellence and patient dealing. And then I came to in 2000 to 2003. Then I came to Raipur in 2004, where I found that the most of 80 to 90% of patients, even for laparoscopic surgery, the complicated case, cardiac, neuro, gastro, they are critical care, they mostly refer to the outside of state. So I feel the difference between the SGPGI and state of Chhattisgarh, newly built Chhattisgarh, because most of the patients, they refer for the higher center outside of the Chhattisgarh. So that create in my mind is that basically Chhattisgarh need a one SGPGI type of institute. And that set my aim and vision. And not only in our department of surgical gastroenterology, I impressed with the HIS system. Like HIS system is new in 2000 in any hospital, in any government hospital. Along with that good infrastructure, they all are responsible for that. Then the second thing is that I choose the capital of the state, because capital covering all the district of the state, and second thing, it also cover the neighboring part of the this adjacent state, like we are touched with the Odisha, Jharkhand and MP. And the second thing is that always choose the peripheral part of capital, not in the central part or in the city. It's the peripheral part of capital is the selection is the good one, because always chances of expansion and growth and low money, low land cost is very important. I started with risk. I belong to middle class family. My father is engineer, and so I started with risk. Initially from 2004 to 2009. I just roaming around the hospital and started a private practice. But one thing is that in private practice, and that time I make 5 to 6 crore this income from my private practice, and my father has a 20,000 land. So he saved this land to build one hospitals or other things. So I took 20 crores loan initial in 2008. And that was the courage to build this healthcare system. And I remember that time I mortgaged all these things, my home, my land, my hospital, everything to the bank, and bank agreed for the 20 crore loan. And you know that the 75% only bank will provide, otherwise 25 rest, you have to arrange that. So that is the initial point in 2008. Then the second thing is that the discipline, financial management, and property revaluation every 3 years. Because once you start the hospital, so initially you don't have your profit, your goodwill. But once you start the hospital, your profit, your goodwill, your high credit score, and go for the different bank. So in 2011, I applied for the 40 crore loan. And initially I took loan from the State Bank. Then after 3 years, because my profit, my goodwill, my credit score was good, so HDFC agreed to give me a 40 crore loan. So that discipline, financial management, and property revaluation every three years, that is very important of growing. But you know your potency, your profit, your goodwill. So the major challenges in excellence is that because the local doctors, they don't believe in the surgeons of the local area, because I am the first person to perform the VIPAS there. I am first person to perform the PSRS in Chhattisgarh. I am the first person to perform the THE along with LAR. They are doing APR, but not LAR. Most of the general surgeon, because because I don't have a degree, I did only 3.5 years SRC here only. So I visited peripheral district and I conduct CME in every Saturday, Sunday, and also surgical training to the local doctor, like periphery part, to build a strong network based on the professional trust rather than just business. And the second thing, because of the SGPGI, I know that how to read a research paper, write a research paper. So I published some not a big research paper like Indian Journal of Surgery, cases and case report in the research paper, the research journal, and then that research journal published in the paper, newspaper, for the local awareness of the public. So public can so public will trust us. Apart from that, the second thing, in the Chhattisgarh, I know that the Chhattisgarh is not a rich state. 80 to 90% people, they are either middle lower class or lower class. सो यदि उनको 50,000 से 1 लाख रुपए भी ज्यादा यदि खर्चा करना पड़ता है तो इधर उनको या तो कर्ज लेना पड़ता है, या तो आपको घर को जो है बेचना पड़ता है, या उनको गिरवी रखनी पड़ती है। तो मैंने देखा कि सबसे पहले कि ये जो है कि ये इतना जो मिडिल क्लास वाले हैं और गवर्नमेंट फैसिलिटी उतनी अच्छी नहीं है। तो वहां पर मैंने सर्च किया लोकल नीड में कि क्या चीज की जरूरत है। तो जो जरूरत थी वो ये थी कि आपको ऐसा सेंटर प्रोवाइड कराने के लिए जो कि आपको इकोनॉमिक कॉस्ट में एक क्वालिटी केयर के साथ में अच्छी सर्विस दे सके, जहां मैं विपल्स भी जो है मैं 1.5 लाख के अंदर कर सकूं। और जहां पर है तो मैंने जब हॉस्पिटल जब वहां पे बनाया, व्हेन आई बिल्ड द हॉस्पिटल, मैंने प्राइवेट वार्ड सिर्फ 8 रखे। आईसीयू जो है पहले जो 150 बेड में था, आईसीयू 30 बेड का बनाया और बाकी सब जनरल वार्ड बनाया। और उसके बाद जब 450 भी किया तो प्राइवेट वार्ड बढ़ाया नहीं, 20 रखा, लेकिन जनरल वार्ड मैंने ज्यादा रखे क्योंकि वहां के लोगों की नीड थी और लोकल नीड थी। तो ये सम काइंड ऑफ इंटेलिजेंसी, सम काइंड ऑफ अंडरस्टैंडिंग, सम काइंड ऑफ जो लोकल नीड है उसको मैंने फुलफिल किया वहां पे। Then I go for the CGHS rate, Ayushman, ESIC, and the major thing is that most of the industries they are situated in the Chhattisgarh. We tie up with them like ACCL, NTPC, Balco, Korba, Cisco, Nico, everything we have tie up and doing a best quality care center with the low cost. So from this, I expand my hospital from 150 bed to 250 bed, then 500, then 1,500 bed, and later on, I realized that because of the only hospital running in the Chhattisgarh is not possible. थोड़ा सा 5 मिनट लगेगा. So I expand to the this academic ecosystem. So use of clinical ethics and entrepreneurship is very important. So that certain principle which I tell to residents and all these things. So first thing is that always set your aim high, because you cannot work without aim, you cannot work with determination and focus on them. And aim give you a direction of success, purpose and direction, and a strong motivating factor. Define your aim today and success will follow tomorrow. The most failed or challenged healthcare venture start with the project like let's open 200 bed hospital, let's buy an MRI, let's start a chain of hospital. While successful empire start with the problem. Like why are patients traveling from the 300 kilometer from for critical care? Why is quality ICU care unavailable after 6 p.m.? Why are doctors burning out when patients remain unhappy? So always start with problem and local need, not as a project. That is the first message. And empire are built by those who grip over the problem of local need, not profit. Profit follow when problem are solved honestly and at a scale. Second thing, healthcare is not e-commerce. It's not a computer operating system. It's not a quick entry exit. If you do such, then you will either fail or worse or succeeded without humanity. If you are entering healthcare, then need to deal humanity, need patience, get feedback to correct it. Great Healthcare Institute think indicate what will the hospital means 25 years from now. Will patient trust this brand with their children? So think in decade, not in quarter. Trust takes year to build, second to break, and forever to regret. So empire are built by people who are willing to grow slowly but correctly. The third thing is that that very important thing is our clinical excellence, because clinical excellence is only your powerful brand. So first stabilize yourself, then start making a system and create a healthcare empire. So clinical excellence is not negotiable. Without clinical excellence, there is no healthcare empire. You can market aggressively, you can raise fund, you can buy technology. But if your clinical judgment are poor, ethics are weak, doctor staff are unhappy, empire will collapse. Maybe not today, but definitely tomorrow. So as a doctor entrepreneurship, our greater advantage to understanding clinical workflow, patient emotion, ethical boundary. So never surrender clinical decision making completely to spirit side in healthcare. Efficacy without empathy become unkindness. So many hospitals survive because of the one-star hospital, but empire are built when hospitals survive even without this star. The shift from individual brilliance to standardized excellence, memory to protocol, heroic to system. Ask yourself, can my ICU deliver the same care at 2 a.m. as 2 p.m.? It must be yes. Does the quality drop when a senior doctor is on leave? It must be no. So build system, build SOP, follow SOP, build culture. Culture is more important than SOP. Let's talk about the most ignorance truth in the healthcare business. Doctor don't leave hospital, they leave management. And that is the fact. But patient don't remember your marble flooring, your sandlier. Patient remember the nurse who listens, the residents who explained, the doctor who stay late. Empire are built when we have skill healthcare deal and management both. We give weightage to knowledge, intelligence, and sincerity of the employees. Doctor feel respected, not exploited. Nurses feel valued, not invisible. Admin staff feel purposeful, not mechanical. So build empire, not infrastructure. So bigger is not always better in healthcare because you can dilute equality, break culture, increase medical legal issue. So standardize, build system, replicate culture, grow where they can maintain outcome. A single adverse incident can undo 10 years of brand branding. So growth must be responsible, not impulsive. So scale with caution, not ego. And artificial intelligence, robotic, digital health, all are powerful, but technology should support doctor, not replace judgment, improve access, but do not widen inequality, reduce error by technology, but not add complexity. The question should always be there. And question should not, is this technology advanced? The question should, does this technology improve patient outcome and clinical experience? So Empire adopt technology wisely, not blindly, but technology has a definite their own factors. So technology is tool, not a religion. So in the era of this commercial pressure, insurance constraint, corporate influence, that over investigation, over diagnosis, so that will not give you a branding. There is no ethics, so everything is finished. So ethic must be there. It is a strategy for long-term healthcare system. Hospital must be known for transparent billing, honest advice, patient-first decision may grow slower. Reputation compound like interest. Ethics is a real competitive advantage. So the healthcare is that where patient trust without fear, doctor work with dignity, young professional aspire to join, society feels safer because you are there to take care. So this all are the take-home message, and blessing in disguise and everything is in positive way, turning the challenge of non-perceiving of MCH, recognition that limited seat option and policy constraint in existing institute, this become the driving force for state level transformation of Sri Balaji Hospital. I didn't pursue the degree, but I got knowledge, skill, and competency. As told by Professor V.K. Kapoor to me when I was leaving SGPJ after 3.5 years, Deven, your degree can give you an initial placement, but your destiny will be decided by your knowledge, skill, and competency. And yesterday, again, he told like the second thing, there is the certain difference between the Vidwan and Vidyavan. So, yeah, so that's the main thing. Everything will be positive. I cleared 3 times theory in SGPGI. I cleared 1 time in the AIMS, and then theory GB Pant, the first waiting in the GB Pant. But I did not get the MCS seat here, neither AIMS nor this GB Pant. But the thing is that I have a skill, competency, knowledge, and patience. So that's the important thing, and everything will be positive. So, dear esteemed, dear colleague, dear friend, I have following 4 practical but heartfelt things is that hospital may be built with money, but great healthcare system are built with the character. So focus on integrity and compassion. We don't build the business, we build the institute that healed the generation. As a doctor, we are privileged as society trust on us. As entrepreneur, we are powerful and growing because of trust. So combination of clinical ethics and entrepreneurship may expand the trustworthy. So this is my personal philosophy. And after this long 25 years, this my personal philosophy is that after entering in the private practice, after getting degree or this completing our this institutional course, then there are the always 3 phase in our life. The first is the foundation phase, second is the building momentum phase, and third is the exponential phase. As we know, 2 plus 2 is equal to 4. But the initial foundation phase takes 10 years. In 10 years, you will achieve your, you will along with your aim, goal, effort, determination, and dedication. But many people stop their effort because of the slow growth of this phase. As the same thing, 4 plus 4, 8, then 16, then 32. It takes 6 to 8 years. And this time you can make system, power, and finances. And almost 99% of the people stop in this phase and they satisfied there. And this is the truth of the life. And we know the power of 32. 32 plus 32 is 64, then 64, 128 for 256, and we can reach up to the beyond that. And it will take only 2 to 5 years, because in this period you have enough experience, system, power, finances. So, but this phase need a courage. So courage is very important thing. Courage. So if you take courage, you can do everything, because 64 going to the 2048, and last phase is exponential phase, and it will take less than 2 years. We are going for IPO and deemed university. Next year we are going for IPO and also deemed university also. So this one is the foundation phase, building momentum phase, then exponential, and most of the people, they are just limited to that building momentum phase. But the main exponential and this things. सो लखनऊ में हूँ, वसीर बद्र की एक है, थाम रखा है मैंने वक्त को हाथों से कि मेरे सपनों की तासीर अभी बाकी है, फैल जाएंगी खुशबू की मानिंद दुनिया में, मेरे सुरों में वो तामीर अभी बाकी है, और बांटूंगा उतनी और बढ़ेगी, मेरे दिलों की जागीर अभी बाकी है. थैंक्स टू लॉर्ड बालाजी भगवान एंड थैंक्स टू अनु बिहारी मैडम टू सजेस्ट मी to deliver this type of how to build healthcare empire and SGPGI team. Thank you very much.
Thank you, Dr. Devan. Your excellent achievement all the front and expanding the health services in the state of Chhattisgarh. The one question, the lighter note, what percentage of health system you are catering for the entire as compared to the government? You
Sir,
have taken over 10% of the entire health system, 5%, 20%.
Sir, government has
The
3,000.
entire health system.
Entire health system, sir. The government has, sir,
You know
3,000.
what percentage of you are catering the health system of the Chhattisgarh?
Sir, it's approximately 40%, sir. 35 to 40%. Because the government has 3,800 bed hospital, and I have, sir, 3,000 bed hospital. The total turnover is, sir, our turnover is approximately, sir, 500 CR, and EBITDA is 37%, and profit is 23%. We are doing with the low profit 23%, but anyhow, it's good. It's basically for the public of the Chhattisgarh.
Profit basis in the title of the population.
Sir, this 35 to 40% healthcare, sir, we are supplying.
I hope you are aiming to cater almost 75% in next 10 years.
Sir, definitely, sir. But not in the Chhattisgarh, sir. We are expanding to Odisha also. There is another, the third medical college. We are starting in the Bargarh district of the Odisha. So that project is going on. The second is the Gondia, Maharashtra is also going on, and a part of this MP is going on. Sir, we are waiting for that IPO. Once we get the IPO, then we can expand not only in the Chhattisgarh, but adjacent states like Odisha, Jharkhand, MP, and Maharashtra also. Sir.
And big applause for it.
Capita percentage is highest in the country. No healthcare system is achieved, including the Apollo. Their range is about 9 to 18%. So about when the profit is more than 20%, itself is a very big. Apollo profit is maximum 24.
24, sir. Our 23%. Yeah, good enough. And sir, average occupancy, just because of the bed occupancy, sir, our 80 to 90% bed are occupied every time.
वो तो मैडम सब लोग लिखा के ले आते हैं अपने अब आप इन लोगों ने लिखा नहीं, लगता है उन्होंने अपना हाथ ऊपर बनाया भी है खरोच के।
सर, लेकिन ना इसमें यहाँ का भी यहाँ था सर, SGPGI नहीं मिलता ना, यहाँ नहीं आते तो समझ में भी नहीं आता सर कि यहाँ और छत्तीसगढ़ में क्या डिफरेंस है। तो एक बहुत बड़ा हाथ यहाँ का है सर, क्योंकि यहाँ जो देखा, यहाँ जो क्वालिटी, यहाँ जो स्टैंडर्ड, यहाँ जो सब चीज थी सर, वो एक जमीन था छत्तीसगढ़ और ये आसमान था। तो जब वहां गए ना, तो वहां पे सर लॉट ऑफ डिफिकल्टी फेस किए। पहले तो सर्जन भी नहीं मानते थे कि आप सर्जिकल गैस्ट्रोएंटरोलॉजी थी, डिग्री भी नहीं थी सर, है ना। मेडिकल गैस्ट्रोएंटरोलॉजी 2 थे, वो रिफर ही नहीं करते थे पेशेंट। तो सब कुछ जाना पड़ा, बहुत मेहनत करनी पड़ी। इवन सर, इवन सर एनेस्थेटिक्स तैयार नहीं होते थे पीपल्स का। आई टूक 12 आवर्स सर फॉर फर्स्ट पीपल इन छत्तीसगढ़। रीजन क्या था सर? क्योंकि एक सेटअप, आप नया सेटअप बनाते हैं तो होता क्या है वहां पे कार्डियक मैंने एनेस्थेटिक्स तैयार नहीं होते। मुझे कार्डियक एनेस्थेटिक्स पहला पीपल्स किया था, कार्डियक एनेस्थेटिक्स को लाना पड़ा था एस्कॉर्ट से। और उस समय सर वो 15,000 रुपये लिया था। दैट 2004 बहुत बड़ी चीज होती है जब वहां पे 7-8 हजार एनेस्थेटिक का चल रहा था। तो खैर उसके बाद भी उसने जब 15,000 लिया और फिर जब 12 घंटे चले ना तो बोलता है साहब मेरे को 25,000 चाहिए। तो सर कार्डियक एनेस्थेटिक्स भी नहीं मिलते थे वहाँ, एनेस्थेटिक्स भी नहीं मिलते थे, है ना, वहां पे नहीं था सर। आई डिड लैब असिस्टेड विपर्स इन 2010। तो बस ये हुआ कि ये सब एक्सपांड करने के चक्कर में जो भी है। अच्छा सर, द सेकेंड एडवांटेज इज दैट द छत्तीसगढ़ इज इंडेमिक फॉर पोर्टल हाइपरटेंशन, EHPVO, hyperinsulinism. So we have done more than 700 cases of PSRS shunt. That's the one thing is there. तो सर लेकिन क्या मेडिकल गैस्ट्रो छोड़ते ही नहीं थे, वो बैंडिंग कर किए जा रहे हैं, इरेडिकेशन कर ही रहे हैं। तो अल्टीमेटली क्या हुआ कि खुद का सिस्टम डेवलप करना पड़ा। फिर मैं खुद गैस्ट्रोएंटरोलॉजिस्ट रखा, फिर खुद एंडोस्कोपी, खुद कोलोनोस्कोपी, खुद ERCP, सब कुछ खुद करना पड़ा सर। क्योंकि नए जगह जाते हैं आप तो हर चीज जो डेवलप करना। और सबसे इंपॉर्टेंट चीज थी सर लोगों को समझना। जो हम जो करते हैं, हम अपनी फील्ड में रहते हैं बट वहाँ लोकल नीड और वहाँ के लोगों को क्या जरूरत है, तो लोगों के साथ में जो इम्पैथी होती है दैट इज वेरी इंपॉर्टेंट सर। और उनकी जो है दर्द जो होता है जो अपन समझते हैं सर।
Thank you very much. Now we close this and one more. No, no, close एक presentation.
Our next speaker is Dr. Pani from Hyderabad, Director of GI, SPP Surgery and Transplant. He will give talk on surgical gastroenterology, JAX or Master of One.
Just a second, sir. Yeah. Firstly, I'd like to thank Anubihari Madam for this wonderful experience she has given us. I mean, the highlights for this was one is looking at our bosses and legends like Professor Vicky Kapoor, Dr. Sikora, Dr. T.D. Yadav, give very personalized insights into their journeys. The musical night yesterday, interacting with all the rock stars of our SGPGI here. And the best, of course, the food. I mentioned it before to ma'am, but the food here, I'm a foodie myself. And this food here was, madam, not conference level, it was Ambani, Adani wedding level. That level it was. So thanks for the hospitality. And honestly, this topic, I told these guys that let's skip this and get on with it. But they said, okay, sir, complete it, sir. Because most of the stuff I'm about to say, the wonderful words of wisdom in Dr. Kapoor's, Dr. Sikora's, and Dr. T.D. Yadav's talk, a lot of useful points as to how you should mold your career. A lot of advice was already there. And most of the guys who are here in this auditorium are so smart also about this career and all. They don't really need advice from a person like me. But let's see. I promise to keep it like really short, so you can be a bit optimistic on that front. So this is the young MS surgeon. So after the MS, your parents, well-wishers come, beta, अब हो गया MS, थोड़ा अभी तो थोड़ा पैसा कमाना शुरू करो, सेटल हो जाओ, शादी करो, एक फैमिली शुरू करो, हाँ कुछ तो करो अपना लाइफ. बट एज यू गो, हमारा एम तो पूरा नहीं नहीं, मेरे को MCH करना है, मेरे को लिवर HPV करना है, मेरे को ट्रांसप्लांट करना है, मेरे को रोबोटिक्स एडवांस लैप्रोस्कोपी करना है. So, and then your journey begins. You're writing your, MCH entrances. Like somebody was saying, first in waiting list, GB Pant, first in waiting list, SGPJ. Somebody was selling all these. Then okay, you get your MCH. At least up to sudhar jao bacha. Nahi. Then you're going to conferences. Anybody who looks from bit from Far East or anybody who's from white skin, he could be from London, he could be from Bradford. You're trying to get their email so that you can get in touch, get some fellowships. Keep on trying for that. All those struggles, failing, getting up, failing, getting up. But finally, at the end of your effort, yes, I've done it. I've done my MCH. I've done fellowship in some Japan. I've done fellowship in some UK. I've achieved it all. And now, yes, I'm ready to face life. So you've completed all your achievements, and you think you're ready to set your career on a great path and become a great master and inspiration for all. In the meanwhile, you have your friends there. They're watching you. Now they're far behind your MBBS friends, MS friends settle down in their towns. They're like, some are saying, hey, hey man, this guy is going to be something great, man. He's going to be no but hey, ये तो कुछ सालों में पागल हो के mental asylum में join करेगा. So they have different views. All your friends and they're looking at you, but yes, you are totally out of touch with reality. You're in your own world. My resection, this, that, and yes, you think that now I'm ready to take the giant leap of faith. I'm going to join the legends and become one of the greats of all time. And this is my this thing in life, and you're ready for that big leap of faith. But at that point, when you feel you have all the gadgets, all the training, and all that, and even then, life throws a big curveball at you. And sometimes you have to start at the beginning. So that is my short GA surgeon's life story. So I was, I was a pretty studious guy and my topper in JIPMA bio. Though I'm also a medicine guy. The only reason I took surgery was I wanted to become a cardiac surgeon. That was the only aim in life. I have to take cardiac surgery. But then once I got into MS, people told me, no, GI surgery is such a wonderful field. You can do upper GI, you can do laparoscopic robotic hernia, bariatric GI cancer. You can settle down in the metro, you can settle down abroad, you can set up practice in a village also. That's the adaptability of GI surgery. But what they didn't tell me was also none of these are exclusive for you. That's because you have, people like Sir Darvaria sir saying, I don't know, bariatric kaise karoge, hernia, you have the AWR surgeons. In every area, you have all these onco surgeons in cancer. So coming back to my career, the first slide I showed. So life show throws a curveball at you. At 35 years of age, I felt I was in an enviable position. I was at 35, I was heading a liver transplant unit at Asian Institute of Gastroenterology. I was thinking, yes, I'm on way to become a master. And then a lot of complex circumstances. I went through a divorce. For whatever reasons, I decided, no, I don't want to work in big hospitals. I want to start my own venture. And then by September, I was doing around 7-8 liver sections and 3-4 transplants a month. In October, I was doing 15 stapler hemorrhoidectomies. And by November, December, I was doing live hernia workshops. So from a master of all, a master of one, sort of which I thought I'll become, I sort of became a jack of all trades. So I'm directly coming to my conclusion. So what I feel, this is one slide that the thought process, because most of you know, have debated a lot about all these things. I think if you're in the developed world, I mean, where it's actually built that everyone is, the system is built in such a way beautifully that everyone has to focus on one area. You don't even have a choice. So that's one way. And in centers in India, if you're working in a great institute like SGPGI or even in the private sector, you have a lot of huge institutes, the centers of excellence or the government institutes. I think it makes sense to become a master of one. On the other hand, like in a semi-urban setup, like people like me, once I became a hospital owner, or like in the corporate kind of sector, you really don't have a choice. You sort of have to become a jack of all. But I think for these people, our target over a period of time should be to become the same message, I think, repeatedly from yesterday, Dr. Kapoor was saying, Dr. Sikkar was saying, you can't be, if not a master of one, at least you can be, because our circumstances are such that you have to put the food in all the hospital employees, you have to pay their salaries, you have to get it going. You should try to become jack of some and master of some. In this, there's one more big danger. Don't think you can ever become the master of all. That hubris is the most disadvantage. I mean, you've done like 2 esophagectomies in a year and one locally advanced esophagus that comes with a post-neoadjuvant therapy stuck all over the place. I'll do it on my own. Why should I call some other guy? Or I'll do you never done a pelvic examination in your life. It's just an extension. I know all the anatomy. Why just do it myself? Why call an oncosurgeon? I think being a master of all, that is like lack of self-awareness and megalomania. Then there is the other one sad story, jack of none. It is possible to become jack of none. I'll tell you how. You're a transplant surgeon. You've done transplant and you're from the top institutes. Whatever circumstances, you go to a second hospital. At that point, you sit on the high horse. Yes, I am this high grade guy. Like for me, I'm from JIPMA, I'm from SGPG, I'm the top. Why should I stoop down to, why should I put some social media ad, or why should I do these small cases and all that? That's lack of adaptability, lack of street smart. So avoid these two pitfalls, the master of all and jack of none. I'll just summarize my message in 5 slides. I think for all of us, the goal ideally in life, it's an oxymoron. You have to try to be a master of one area. That's the best thing in life, because I mean, as a surgical profession, you excel in one, you're too good, everything, financial, academic, publications, rewards, everything is that way. So that excellence is the goal, and excellence cannot be achieved by getting too many things. So always achieved with better focus. So you should always try to be the master of one, but adjust your ecosystem, be flexible. So like I said, avoid hubris. Like, I mean, if your situation demands that you have to adapt, like I was saying, from becoming a pure HPB and transplant surgeon, I've done like about 150 bariatric surgery. I started doing hernia workshops. People might even like, they're thinking like, what the hell is this guy doing? But at that point, and I was enjoying doing that. So avoid hubris and adjust your ecosystem and be flexible. So, and again, reiterating the message, I think the most important message for all of us in India who are outside the institutes, all my brothers who are not got jobs in premium institutes or centers of excellence, we should always be a jack of all trades and but master of some at least. Like, for example, once we in our hospital, when we started developed a big team, I had a team of 3 guys who do all the hernias, fistulas, fundos, all this surgery. And then over a period of time, I focused this thing back on HPB oncology. And in transplant, we had another transplant surgeon. I started doing only donor surgery. So you just try to master one area and focus your academic and skill acquisition in one area. If not, it'll be very dissatisfying. I mean, people of our level, of the people in SGPJ, always just settling in life and financial is not going to be satisfaction. We should feel like, yes, 20 years later, you should go to a place, should be a head held up high, that you're excelling in something. So focus, even if you're a jack of all, focus your academic and skill acquisition in one area. And this one more thing I'd like to tell you. So there are a lot of guys, I mean, youngsters, you're going to do fellowships abroad. I was in the UK for 2 years, and you might go to some Medanta or one of these places and acquire HPB transplant skills. And then life throws a curveball at you, whatever situations, you have to become jack of all trades. Never think that that's useless. Never ever think that all the training of that is useless, because I look at Superman, for example. Superman in Krypton, he was like nothing. Here's this one more regular guy in the whatever the red sun of Krypton or green sun of Krypton. He was a normal guy. But on planet Earth, in the yellow sun, he was Superman, master of everything. So if I'm a transplant surgeon, I've got the perseverance to do those really complicated procedures, massive bleeding, disasters, able to handle crisis. I've got the elegance and the entire knowledge of critical care, how to manage things and all. For me, doing a complex pancreatic resection, all that is going to be drilled down. Not even that. Doing a really difficult hernia surgery or something like an E-type or something also, surgical skill never goes waste. The attitude, the perseverance you develop, the abilities you develop would never go waste. And again, the master of all thing, like I said, don't bite off more than you can chew. Even now, today, like for example, I would have hardly done colon anastomosis. Yeah, we do less because in private it's less. So if I have a colon anastomosis, even now I just call my oncosurgeon colleague who's at least in his training has been better trained there. So I ask him to come and do it. So because don't bite off more than you can chew. You've not done an arterial anastomosis for like probably 5-6 years. The first case, no. So the first arterial anastomosis I'm going to do, call a vascular surgeon. So this master of all is the most dangerous. You could be master of some, master of one, or jack of all, but master of all is to avoid. To conclude, does it matter? Should you be the master of one, jack of all, or like I said, should be the master of some or jack of some? First thing is, with due respects to, sir K. Singh was saying how getting a financial achievement and making a really high financial goal is right. And how Devendra was saying establishing an empire and making a difference is a big thing. Also do all that, but also stop taking yourself very seriously. Don't make this about you. So this universe is supposed to make me a master in some area. The universe is made to me extremely successful in the world. There were thousands before you, thousands after you. It's always the flow is going to go on, go with the flow. And in my case, like for me, what is the thing? I think peace of mind. Right now, my mindset is tomorrow it might be finances or something else, but right now my mindset is if all my patients are happy, I'm like the really happiest person on this planet. So I think just do what's best for your patient and you'll be safe. Thank you. Telugu Bahubali, sir.
It was really nice presentation
and short, I hope. Short.
I'd gone through this phase. So when I started GI surgery, I was doing very good. But one day I decided I want to do only bariatric surgery. In 2006, I declared that I will not do GI surgery now, and I'll do only bariatrics. Now, my own patients will go to gallbladder surgery somewhere else. They don't even consider as a GI surgeon. So, but I'm happy, whatever I'm doing, at least number of bariatrics, they do all over.
No, I think the aim for anyone should be to excel in one, sir. And but you should also like see, for example, I've always been working with a big team with me. So if tomorrow, if things are going good, I can just stick to one area. And I mean, see, in private practice, it's also about you have to feed the mouths, your hospital, your payouts, all that. So I think you should be adaptable and but always focus on one area. If not, I think people of our caliber of SGPJ, if we are doing become jack of all our lives, we will listen, we'll be dissatisfied towards the end. Thank you.
Yes. Now, Ritu, what first?
I mean, I have realized in private practice, as you saw in my talk, we have a strict discipline in our place. But the problem is that all those specialized people will do general, correct? Nobody wants to let go.
Yes, ma'am.
Yes, hardcore GI surgeons don't want to let go. General surgeons don't want to let go. I mean, your talk has a point, but the new generation is such a big challenge for them that
Yes.
at the end of the day, they don't get it.
So that's what we could do everything, but you should have your focus on one area. If not, it'll be like terribly dissatisfying.
The other way around, what Ritu has told is also basically right. See, when I started my practice, I was the first person who has been trained in Sanjay Gandhi as a GI surgeon, 3-year residency, and when basically I went to Indore, nobody was doing that, anything, no advanced lab, nothing. So I pushed my colleagues for, say, urologists, for lab, nephrectomy, radical nephrectomy, myeloplasty, gynecologists for TLH, myomectomy. The surprising thing for me, they haven't learned, but I learned everything.
Yeah, that's right.
So still, you don't believe. Monday I did one lab for times for one surgery. Last week I did one lab donor nephrectomy. Last month I did thymectomy thoracoscopic for gynecologists. So such kind of patient also will come to you. When gynecologists themselves, anesthetists, and they ask for help. So definitely medical legal is the issue. So what I basically do, I always keep one specialist. So I'm doing say thoracic surgery. There is one CVTS surgeon in my room. If I'm doing radical nephrectomy, one urologist is there. If I do organs, one gynecologist or operation is always there. So this other way around is also.
I mean, one thing is there's no one single way of doing it right, sir. I think here, if you look at each of our careers, they're all like different, varied pathways, and each is right in his own way. And see, if you're not doing justice for the patient, it's a self-correcting mechanism. We'll always fail. Yes, sir. Yes, sir.
What you said. When you say that you got to be jack of many trades, I hope I got your point right. You said jack of many trades and master of one or few.
Yes.
Right? The concept of jack of many trades is only for revenue. Am I
Yes,
right?
yes, 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 sir. Keep
I'm
your
asking
unit.
you, please. Is it only not for revenue?
Like, sir, I've nearly not really thought of this topic too much. After Anu Behari madam gave me the topic, I started thinking on it. So I've not really thought it too much, sir. It's like, see, it's revenue.
This will not get debate in fact. What here is your pain is point you. So the best would be you can discuss in and debate it in another.
Yes.
Thank you.
So, so I think what we are discussing right now is it's from our time. So it's last 30 years what we have experienced. But we have to understand the new generation and new problems with the new corporates, and they are just going out precious. They have all the experience in the expertise in that field. They master, but they don't have a recognition. They don't have that much finances because now they have to pay to the corporate. So I think their problem is some different.
So for them, I think they should make a team. Okay,
Yes.
at least 5 to 7 individual. What you say,
Absolutely.
check of one. So individual they do collaborative practice over the period 5 years. They can individualize in which sector they want to go, and at least 5 or 7 people, if they stay together, then only they will survive.
Absolutely.
So.
I think my take-home message is you should be adaptable, but final goal for a really satisfying career should be excelling in one area. That's definitely my take-home message. Thank you. Yeah.
Wonderful season. Funny, really, really. See, my message is the same thing only. If the plan A doesn't work for any surgeon, for any human, shift to plan B. And my daughter taught me, she's around 19 years old. She taught me, you are lucky, you have alphabet still listen. So if A doesn't work, plan A doesn't work, plan B, plan C. Just like that, at the age of 36, after all the transformation, everything, I moved my hometown in Toronto. For 1 year, I worked in a very big corporate with all the nuances. Immediately, exactly at the end of 1 year, I shifted to a meeting I was set up, Global Medical College and GG hospitals. Last 13 years, with good amount of peace of mind, and nobody asked me how many days I will give over last one. So plan A December, plan B, plan C. Thank you so much.
Thank you.
And I'm a copycat. 99% of my jobs are copycat. I'm going to copy that Bahubali video.
Mine is also copied from Abhishek at my conference.
Can copy from everyone, right? Thank you so much.
Thank you.
Very purpose here, all here.
Thank you.
Thank you. Now its session is closed and it's over to our Nigel.
Thank you so much, chairpersons. Before we break for lunch, I request you all to stay back for one more session. This was initially the part of the academy program, but later had to be dropped. Our next session is by a very senior alumni, Dr. Raj Prasad. He has expressed his deep regrets for not being able to be here with us in person, but he's been very kind enough to send us a recorded version of his session, which we'll be playing now. So to introduce our next speaker, he's Dr. Raj Prasad, who is currently the section chief and surgical director of liver transplant at the Medical College of Wisconsin in the US. And his talk is going to be on surgical gastroenterology to liver transplantation, the journey. We'll be playing his recorded presentation with the audio in a few minutes. So I request everyone to kindly stay back for a few minutes before we break for lunch.
नहीं प्ले हो रहा इसको नहीं प्ले हो रहा नहीं प्ले हो रहा सर वॉइस नहीं आ रहा
Yes, ma'am. हाँ हो जाएगा मैम. हाँ, we'll run it simultaneously here and there both.
Session
उसके बाद
3
liver transplant वाला है, उसके बाद showcase है. हाँ.
We'll
हाँ,
make it outside also.
we'll keep it playing. Sir, sir दोनों जगह play कर देंगे.
दोनों जगह कर देते हैं.
ऑडियो बाहर आ जाएगा सर, एलईडी स्क्रीन में आ जाएगा. Sending it to Julian को भेजता हूँ. Yes sir, मैं जुगन को भेजा कोई कुछ
ये तो हो जाएगा पर वॉइस नहीं आएगा सर. वॉइस नहीं आ रहा है. पता नहीं चल रहा. पहले कभी किया नहीं मैंने यूज और जूम के साथ तो और भी डिफिकल्ट होता है.
इसके बाद क्या है सर? बस एक बार लोगों प्ले कर देते. हाँ, रिकॉर्ड करेंगे. इस सेशन के बाद लोगों प्ले करेंगे. ठीक है, सेशन होने वाला है. ये रिकॉर्डेड
फिर बढ़िया नहीं होगा। Guys, चलो मैं करता हूँ। So good afternoon, everyone. We get second half of the last day, the 25th SG week. So coming up in the third session, we have a panel discussion on starting and sustaining a liver transplant program in a public sector hospital, challenges and the way forward. So may I request Dr. Piyush Bhaskar sir to the dais as the speaker, and he will introduce the panelist. Thank you.
Thank you. At the outset, I'd like to thank Anu ma'am for giving me this opportunity. Just to begin with, before I call upon the panelists, I just start with this quote from Professor Starzl. Pardon me for my voice because of the cricket match today. History tells us that procedures were inconceivable yesterday and are barely achievable today, often become routine tomorrow. So this is the state of liver transplant now, at least in our country. So to begin the panel discussion, I call upon the stage the esteemed panelist, very senior panelist, Dr. T.D. Yadav sir, Head of the Department, PGIMR Chandigarh, Dr. Abhijit Chandra sir, Head of the Department, KGMU Lucknow, Dr. N.R. Das sir, Professor, AIMS New Delhi, and Dr. Biju Putakat, Professor and Head, Department of Surgical Gastroenterology, JIPMER, Puducherry. Just a brief introduction that around 40,000 liver transplants are performed today as we talk globally in a year, and India stands to around 6,000 liver transplant in a year. And of course, India leads the world in living donor liver transplant, and it accounts to around 80 to 90% of all the liver transplant performed in India. The reasons are multitude, like low cadaveric donation rate, cost effectiveness as compared to the Western centers, large pool of skilled transplant surgeons and high volume centers that we have in our country, and of course, well-established evaluation and surgical protocols that we'll discuss later on. So I just begin this panel by asking TD Yadav sir, why government centers should do transplant? Why should they start taking up the lead and they should do the transplant?
So I think this question is very pertinent, and we are lagging behind also. So why government made institutes? I think the basic aim of any institution is produce good doctors for the future, so that in the country you should have the next generation should be smarter, more competent than the present generation. And that's why these people to go to the society and to help the society in a better way. So first motto is this. And because of this motto, if you have a government set up transplant centers, you are training more and more people. So unlike, please don't mind the people in private hospitals, unlike private setups where you complete your degree course in a good setup and you go and do a fellowship. So your training is limited to that particular area, mainly technical, more of the technical and practical experience. But to know the whole physiology of the things, and you are trained in a center where you have to appear for the exams. So exam pressure, peer pressure, and academic schedule which is being followed in any government institutes are very strict. And with that, you are training the people. And second most important is cost factor. Like in PGI, in AIMS or in JIPMER, wherever we are working, you can make it poor free so that your most of the things are become free. And most of our people, I cannot vouch that we can go and operate poorest of the poor because still people don't come, and maintaining the things after transplant is also one of the very big challenge. But at the same time, low middle class people and even some middle class people who are not government sponsored or nobody is sponsoring their transplant program, they also can be taken care of in the government. So I think it is important that we train people, we train good people to the society to go to the different centers, and that is why it is the most important responsibility of the government setup to work hard to establish transplant centers so that they can produce future better doctors for the society. This is my opinion.
Any other panelists would like to add something?
One very important thing is that liver transplant is a very complex procedure, requires interdisciplinary management, and I would say that in institutions, it is one program which raises the standard for the entire institution. You have to make better your pathology services, radiology services. So it's overall good for the institute, to raise the overall standard of care. So that is one thing which I think we experience. We never used to have tag levels. So, pathology department exposed to interventional radiology improved. And so in general, it is good.
Basically, it's the enhancement of the whole institute.
Yeah. Of course, cost is factor here.
Of course. Yeah.
I think the importance of liver transplant in development institutions. One reason for the Kerala paradox, Kerala is supposed to be literacy very high, but the transplant approach for the public is very meager and very disappointing. One reason is that suppose this particular treatment modality is freely available and easily happening, frequently happening in government sectors, it is easily accepted by the public. In Kerala, it hardly ever happens. Only one center in the government sector, hardly maybe 3 or 1 or 2 centers, hardly 2. This is one important thing I think Dr. Biju can take it forward because he's supposed to make a huge change in transplants in Kerala in the coming years. This is one important reason for Kerala. It's not suppose it's a keyhole surgery, it's happening everywhere in the government sector. Suppose it's a liver transplant happening everywhere, then it is more acceptable to the public.
I think what you're referring to is DDLT, LDLT might not
anything, sir.
But DDLT, I think it was me.
Sir, would like.
So let us start with the chronic liver disease. So this is a surgery for a problem. Okay. So when you have a large proportion of patients waiting in the population, government data itself showed that it is close to 50,000 requirement for liver transplant now. The fact is we will not be able to cater despite multiple centers in the existing centers. That is it. The data what you shown, if you adjust to million population, India performs very poorly across the world. The data we are getting, a good number are from patients operated from abroad. Corporate sector unwilling to share full data to the government of India. So this is the bottleneck where we are sitting right now. So how to make a difference is you need very high volume centers doing consistently this job. You will not be able to make any change if you try to feed more and more to the existing surgical gastroenterology or surgery system, because whatever we boast of, at the end of the day, only ILBS would do more than 100 transplants in the public sector or IKDRs. So the number is very small. So we are sitting at a very large public health program. And we are finding solutions through small departments which are doing colorectal surgery and other surgery is absolutely not good.
Yes, that's I'm going to discuss in subsequent slides. So obviously there is a huge gap in demand and supply. What the data suggests that we require around 60,000 transplants annually, that too for the Indian population. And the annual number of transplants that Biju sir already mentioned is around 6,000. Of course, out of which a large proportion is the foreign individuals that they come to our country and get transplanted. So this is the data updated till 2022 at Ministry of Health and Family Welfare website that shows around 761 transplants done, deceased donor done in 2022, and around 3,000 transplants living donor in 22. This data today is around 6,000. So setting up a new transplant program in a government sector, there is a need for this program. One aspect is the recipient outcomes, one is the donor safety, and of course, there are multiple challenges for this program to happen. So just a brief comment, sir. As we stand off now, currently, what is the public sector contribution to liver transplant? Nihar, sir? All over the India.
No idea. What I have to say is, all of us know what is the data. So what is there to ask about the contribution? We have to understand 2-3 things apart from your question. The question is very straightforward and everybody knows the answer. Now, how many poor patients have been operated for liver transplant in private sector? 0. Okay. Now, second point is the transplant, liver transplant, as you said, it's a very difficult thing. I operate in both the things. I think operating on a higher cholangiocarcinoma with vascular reconstruction with the intact liver, intact body.
It's more challenging.
And yes, more challengeable operating on a portobelliopathy, dissections, reconstructions are much more difficult than a straightforward liver transplant. That we can mostly EDLT. If you don't do it, it's not a problem. Our students, and most of the people who are passed out, they are ready to help the government hospitals. They are helping. They're coming, operating without money, and they never hesitate. Still, it is not able to take out. The answer is 3. 1, money. Second, money. Third is money. Now, what is the difference between 3 monies? One is patient unable to afford. If he is able to afford, he needs a little bit better care, less infectious environment, and less nursing care. So they will go to private, they have the expertise and they'll do it. They have the money. Second, the connection between the government and the institute. The halfway the government leaves you. It's understandable because they cannot say they give 50 lakhs. In 50 lakhs, so many rotavirus patients can be survived. There is a huge number of deaths other than liver transplants. So their hands are tied. If they give you 5 lakh rupees, 2.5 lakh rupees, or maybe they are supporting the surgery to what is happening after the surgery. We have operated 3 live-related liver transplants. Very successful. Day 7, day 8, they were discharged. Very well away from Guwahati. Nobody was able to even do a sugar testing in them. And one of them died on the way while coming here. Then I had to ask some railway person to get an ambulance half the way, collect them, and I will have to bury that person near that is hi-fi. What is that? Sci-fi. Sci-fi. So this is the situation. Khali, if you do it, what is the big profit? Then you have to support them for next 4-5 years. That is second. And third part is the what is happening to the government sector. So far as the see in ACPGI, we did 14 cases consecutively. And then what happened? Nothing. Then second thing, I went from here, I went to AIMS. We also tried, we succeeded for a few years, maybe 5-10 years, and nothing. Now, what is the problem? The problem is, where am I getting the incentive? With the same amount of money, if I have to do gastro surgery from 8 to 8, then where is the expertise? Where is the manpower for liver transplant? So these are genuine problems for which liver transplant problem has started very well in many places. Maintenance has been problem. And wherever there is some money involved with liver transplant in government sectors, things have gone up to some extent. So that is the thing. It's not a matter of numbers. It's the attitude or the system or the setup. The no depth in manpower or expertise. That I can say.
So very true that we have the skilled manpower in government institutes, but still the numbers is not being able to take up. Around 90% of the transplants are done in the private sector in India as of now. I think more than 90%.
Can
Yes,
say
yes, sir.
because we all are working in a government, even you can find. So I think there is a attitude issue. And there is a, as somebody told, show that picture of orchestra where everybody has to go in the same tune. And master starts there and goes on moving his hand. And like a classical music, if tabla is another tan and this guitar is another tan, and you go and have a sur is somewhere else, you cannot produce music. So important issue in government is there is a big issue of attitude problem, leg pulling, and this is your baby. In an English doctor case is there. So ये तो उसका बच्चा है, इसका नाम हो जाएगा. So you have to beg to everybody for small things. Motivation to have a institute going above this thing, higher and higher in place like this thing, and everybody not getting everything. So suppose you are leading the team, your name comes in the media, the person who is somebody helping from biochemistry department, from immunology department, from infective department, from multiple departments, they have not the same motivation. So I think it's a big issue of I think for the transplant at the center in PGI and games, there should not be a problem of money. You can generate money if you are motivated. There are so many people to help. The issue main is infrastructure is stagnant. So something which was made about 40 years earlier is still being used, not being updated, and faculties, most of the faculties in other departments and in your departments also, they are not equally motivated. So there is interpersonal relationship issue, and there is attitude issue, there is an ego issue, and suddenly you become very big once you are in a big government institute. So you don't want to, Dr. Prasad writes a humility that all of us are there for the benefit of the patient. If everybody is involved, whole team is involved, department as a whole is involved, then there is nothing big issue that it cannot be done, at least for the DTLT, what I am trying to say. So, okay.
So I think we have discussed a lot about why do the government centers lag. Next, we'll discuss the solutions. So this is one of the comprehensive slides which I tried to summarize that why do government centers lag in doing the transplant. So broadly categorized into the 5 subheads. One is the most important, the financial and the resource constraints, limited funding and high cost, infrastructure and staff shortages, and high out-of-pocket expenditure incurred by the patients. It's not only the transplant, the 15 lakh packages that we get, but what is the extra cost that the patient needs to pay apart from the package is never calculated. Obviously, organ shortage and donation issues are there. There are logistical and operational challenges because it requires complex coordination, inefficient referral systems, lack of centralized registry, and safety net specific barriers like obviously that everybody sees that there is a delay in referring by the general physicians or even the gastroenterologist for patient for the transplant that should be done at a new transplant center. And last are the ethical and regulatory issues. So Biju sir, would you like to add anything or would you comment upon anything from these issues?
It's not a problem of money. Next thing, the Honorable Prime Minister 3 times in the Mann Ki Baat has told that this transplant is important. 2026 budget, 15 crore is the only amount allotted to the entire non-auto for the country. This is ours. While aims receive 5,600 crore per year. So this is the budget. So in that 5,600 crore, one institution receives, not even 1 crore is spent for liver transplant. This is a fact. Government is leading. So we should not get an idea that the government is not proper. They are willing to invest. But how many public sector institutions are willing to give a proper idea of how to spend this money in the ground level. That is the exact problem we are facing. When we put that whatever proposal for setting up the system, you have to put a very dedicated system and ask money for that. Government is more than willing to do. That's what at least most of the administrators feel so. Especially South Indian governments are very much motivated. Second point is donation rate, cadaver donation rate will not improve with the motivational campaign. The highest literacy rate in the country, Delhi and Kerala, performs lowest in the disease donation. The disease donation rates are high, not in the highly publicized area. It is because the systems and practices you put in the ground level, the mechanisms you put in the ground level, who will come when you are certifying. This makes a huge difference. That is how Maharashtra made a difference. That's how Tamil Nadu makes a difference. Telangana made a difference. So this aggressive campaigning is not going to convert into higher amount of disease donation. These are the two things I just wanted to point. So finance is not an issue, and aggressive campaign is not the problem.
I think one very important thing is accountability. In government sector, you don't have accountability. You have to fix responsibilities. You have to penalize people who don't do their duties. Like talking about donation, I won't quote specific instances, but in general, there's a lag in conduct of apnea tests. People don't come in the middle of the night to do it. And it's not that the organs are not there, but in general, the system failure is there. There's lack of responsibility, and there's no sort of punishment, I would say, or fixing responsibility. That's lack of attitude and in the government sector. Because it is implied that your job is permanent. No one can do anything. And so that creates laxity. That's one thing. And hire and fire, which is prevalent in private sector, actually makes you go. So you have to have some mechanism where you have to fix responsibility.
So, as discussing about the solutions, so as already Biju sir mentioned, that there is already a national program in place. That is the National Organ Transplant Program, NOTP. These are few guidelines, or you can say the objectives of the scheme that are being laid down by the NOTP. I would like to ask each of the faculty, is it really in place or really effective at your workplace? Do you feel that, is it really so?
Money is the problem. Okay. It's not what it sounds like. 5,600 crores are nothing being used. This money is not for everyone. The constituents of the patients, it's only for BPL. Then they have to run after the cards, not even the ration cards. There's a lot of things behind the screen until it's just like I worked in periphery in the remotest areas of Odisha. If you see the picture, UNESCO gives so much of money, government gives so much of money. By the time goes there, you know what is the truth. So money is the problem. It's not the cutting only that is it. You give me, I am the surgeon. You give me, that's what the ILPS has started. Somehow in other cases, you give me 25% of the expenditure and see how the things should be going on. Give some incentives. That's not there. A person 9 to 5 in a non-clinical goes get the same money to the person who works from 8 to 8, and then if it is a transplant, I was there in transplant, I and Dr. Rajan Saxena were sleeping with a patient in a single room because nobody, and people said, why should we? So that is there. Third thing is leadership. That is what is exactly is lacking in the government hospitals. The leadership is very, very important. Now, see, the leader gets motivated for some time and then loses. They get some credit, then hides it what is happening, not happening. Now, you have to build up a team. I am doing esophagus, colon, everything in the morning, and then I expect to do a transplant tomorrow and then make it a regular thing. What is a regular transplant? Means at least In a month, you do 4 or maybe 3. You say this a sustainable transplant program. And if I'm doing one case or I'm doing a liver live related, I need 2 rooms. And all should be sterile. And then there has to be nurses, there has to be technicians, sweeper, dedicated for that, and dedicated senior residents. They have to be there for 24 hours or 5-6 days. These are the practical, I'm telling. Why it is not, we're having problem. Ask our residents. They have practically no relief, they continuously go on working without off. And when there is a transplant, then the entire routine goes haywire. Who will go, where will go to OPD, will go to. So all these things has to be there. So in my opinion, now we have discussed many times in the ministry regarding this, why it is not taking up. I have spoken to minister also. They have given in writing, they had asked for. So the thing is, you expect us GI surgeons to do everything and then also include transplant, make it a regular program. It is near to impossible. You have to have a unit, declare it as a liver transplant unit or a center separately in the government. Let them focus, appoint your faculties and team. It will pick up. No problem. And I am aware in many hospitals, money may not be a problem, but I've seen much more help from other people, like in Tamil Nadu. So there's much more help from the government, particularly in this aspect, percolating down towards the transplant. But team build-up is very clear. You have to see what is your workload and how. So I think lack of team and lack of time is one of the major causes now.
Yes, of course, this has already been talked about that some of the states have done excellently well, like Maharashtra, Telangana, and Tamil Nadu. Because at some places, government is also supporting the organ donation, whether it being the last rites or some amount of incentive given to the donor or the donor family. In our institute, the nearest kin of the donors get free treatment for rest of the life. So these kind of perks may help in disease donation, but still it's not at par when we talk about the demand for liver transplant in our country.
See, just give you an example. AIMS Trauma Center, every year, 110 minimum dead donors, dead. Now, what is the output out of that? So it is the team effort. That's not there. There's no coordination. Maybe a poor coordination between the trauma people, the neurosurgeons, the case, and then coming up with coordinators, the motivators. That is lacking because they in private hospitals they are after it to see that things, which is good. I'm not telling that it's bad for money purposes or something, because transplant constitutes 10% of the GSS total. So for picking up that, you have to need separate motivation, team, and effort.
Yes, excellent. So obviously dedicated teams, cost and facilities are needed. That is why I hope private centers are doing well. Another thing is the referrals and kickbacks. So, Biju sir, do you agree that when we talk about the transplant in private centers of packages of around 25 to 30 lakhs, these referrals and kickbacks play an important role? Because in government centers, we do not have such perks, or, we do not have the such liberty for these kind of referrals and kickbacks.
The population in the government sector caters is quite different
Yeah.
from private sector. It's not that poor sections of society don't need transplant. We have patients, not that, and it's a different kind of patient setup, which comes to us in government sector. And in private sector, of course, be a factor, but generally those patients would not come as of now to government sector, especially for liver transplant.
Okay. Most important thing is the incentive and the drives, of course, to the team, and of course, one is to the donors. For the team, I think, what are the solutions? What incentives can we thought of for a team so that we can work in a government center? Yeah, PD sir.
I still feel for the doctors working in institutes. They don't need any incentive other than what perks they are getting for their salary and all those things. But the question is, you understand the cycle. So cycle is that trauma center, patient comes and SR neurosurgery or whoever is there, who is taking care of all the time in PGI repeatedly. Our center, sorry, not the mine. So he is taking care of whole emergency. The moment there is a patient who is probably becomes MM, so the practical problem is we are not supposed to go there. The practical problem is who is going to take care of them. For a neurosurgery registrar, it's an extra burden to go and take care of the patient who is not going to make it and who is not going to the operation room. So first hitch is there. After lots of motivation, suppose we are talking to other consultants and makes a register, then he will put a WhatsApp group to the coordinators. Now it depends on the how effective the coordinators are. Suppose there is no transplant, the coordinators have no work. What I mean to say that there is a lots of lethargy, stagnation at different levels. We have to analyze that. We cannot just blab. If you want to improve the system, we cannot ask for the sky that today give me one department and donation is not one even in 1 month who will give you transplant department. So at least you have to produce that every month we are doing. These are the brain dead and these brain dead patients. Out of those brain dead patients, how many have been translated to go to the operation room and transplant being done? Until and unless you show that this is our volume, what will we have to the center? Suppose you are having that. So we have to go other way around, to my mind, that we have to push it little bit extra effort. To my mind, this is the one area from the trauma center, lots of burden in the trauma. From that center, going to the coordinator, and from coordinator to the team, lots of time wasted. Patient become infective. Patient becomes this thing. There are suggestions that you should have one area for that particular area. There should be a separate team, which especially are the nurses who are not supposed to see other patients other than the patients who are M2 or going to be M1, where there is no neurosurgical treatment is required. They are shifted there, and these nurses they are going to take care of those patients in specialized area, and they are not supposed to see other patients. Then one of the registrar probably takes care there, and then from there, coordinator also to be fixing responsibility that I suggested to our institute also that take a list from the Department of Neurosurgery. How many patients were enrolled in that particular month or even 15 days? And then how many of them were informed to the coordinator and how many of coordinators they put it in the WhatsApp group in that particular day. So you maintain a register. So the little bit of stagnation you can cut short here. Regarding the same people doing the same thing, the moment you have a transplant, everything goes stops. So if your transplant numbers increase, obviously other surgery will go down, and there are people who do other surgery also. It's not compulsion that you go and do a fistula operation or a GI operation or there is a transplant. So first you have to say that we are overburdened by the transplant, by crossing all those hitches. So hitches are there in the then you can suggest that now see because our now numbers have increased, we need more and more support. So basic problem is in the post-operative staff nurses availability in government setup. As Dr. Das said, it's very difficult for the DNS to say that give me one to one. Like in other setup, people say one staff seeing one patient. We have to struggle. So level 2, level 1, level 2, level 3, everywhere there is 1 and 1. She doesn't see any other patient. So cross infection is not there. So these are the things which can be managed to my mind. I still feel very sincerely that it's all. And regarding the fund distribution, sir, there is a difference between government giving fund to a government setup will be used in a rural area, and there is a difference between the fund allocated to AIMS and PGI and Jodhpur and all these Jipmer. Because this fund directly go to the under the director. There is a financial advisor. The director of the institute, if he is motivated for the transplant, he will say, look, at this year, I want this particular, rather than throwing this money to the experimental department. which have not contributed anything till date in this country. There is no better, even tuberculosis medicine, tuberculosis, we are still WHO criteria, not Indian this thing. So rather than throwing money in the name of research, we can take a significant amount of money and shift it to the transplant. So it is totally in the hands of director and local people. So this is my opinion. I may be wrong, but I feel that these are the level of the stagnation. Then department. How much is the department, head of the department motivated for the transplant? Then how much the team? All the registrars, I am sure all our boys sitting here, we also without transplant, we work 24 hours. If there is a transplant, they get energized. They become more energetic. Their lethargy is gone and they work very hard. They don't even say once that sir, transplant हुआ, आज मुझसे चला नहीं जा रहा. I have never heard at this. So I think all the things are manageable, provided, I am repeating, provided these small steps can be taken care of. And Dr. Biju said, how most important, how the donation increasing. Once your donation is there, once liver, these are the things being invested. Obviously, everybody has to come because government is asking every time, how many transplant, how many transplant. It is all coming to this thing nowadays.
Next, I think Biju sir, would you like to comment on this? Like we have a totally overworked gastroenterologist, so they have come up and divided gastroenterologists and hepatologists. So is it the time that we should also start HPB surgery and transplant institutes?
For that, see, after 20-25 years, we are discussing probably the same problems. Okay. So how to increase the donation rate, how to motivate the neurosurgery, all this. But what ultimately we have to realize is, there is no ecosystem in place. We cannot produce high numbers. Right? People are willing to work in public sector. People are willing to work in institute. Why there should not be a surgeon who can do liver transplant on alternate day? It is there. That willingness is there from people or specialists joining the public sector. They are willing to do. But there is no ecosystem. That is the basic issue. Okay. Whatever you do in existing system, current surgical gastroenterology departments probably may not be able to do more than 3 per month. So that will translate into maybe less than 50, which is defined as a low volume center according to international standards. So this is not going to work that. So the solution is we have some small models. Let us say there is a kidney transplant surgery department in PGHND. You see the ecosystem there, everybody talks about the same thing. Everybody does similar thing, and the volumes are high, 500 plus 600. So when you want to produce a center or a department which produces more than 500 kidney transplant a year, 300 liver transplant a year, 50 plus heart and lung transplant a year, it is impossible to do in any of the existing departments. This only will solve our problem. So just now I had a talk with Dr. Ajit, but I was also telling that the cadaver done straight in KGME came down. KGME was one of the very hope for many things. Okay, many institutes actually came down. So the solution to that is creating because even in NATO, as you told, National Transplant Program, we discuss it as experts, we discuss it day in and day out. Solution to that is creating an ecosystem. How to create an ecosystem? That's what some good places are coming. At least now, the central government is very unwilling to or not in forefront to invest. So we have some state now because health is a state subject, some good news or something. So the good news in some form of, let us say, government of Kerala has decided to establish an organ transplant institute at 600 crore. Okay, this is at least some good news. So this 600 crore hospital is probably going to come. Government of Karnataka has already announced last month that they are going to build a transplant hospital of 1,000 crore only for transplant. Okay. Most likely in another 20-25 days, we may get an announcement from the Pondicherry, Tamil Nadu region that there will be a transplant hospital which will be built at 400 crore around. This announcement is most likely going to come. Maharashtra government is on the verge of preparation of this announcement.
So if you have this system, now imagine that after 10 years, you have huge hospitals dedicated only for transplant. This is going to transform. Okay. Rather than discussing about the existing surgical restaurant, the existing kidney transplant department doing this, caught up in multiple problems, are you doing colorectal surgery than this? Instead of that, you enter into a 300 or 400 bedded building. Everybody from transplant surgeon to the head of the institute to the nurse to coordinator talking only about transplant. The ground floor is managed by emergency team. Cadaver is coming, ambulance is coming. This is what the ecosystem. This is the only solution to a country which has more than 1 billion population. Otherwise, we are going to discuss about the same thing. Why should we give an incentive to a surgical gastroenterology person? He's doing a Whipple surgery, he's not getting incentive. He is thinking that it is an additional work for it. So let us make it a routine one. Okay, we have excellent private centers which show that a department can run only with transplant. Then you can run it. So there is a model to show. You replicate that exact models in the public system in the form of a single building or whatever, then probably the system is going to work. But I want to let things are not very dark now. At least some horizon, some things are coming.
But I think many departments, especially institutes, renal urology has separated renal transplantation and they're doing good. So don't you think that if with our branch also, this could be a solution?
Yeah, see, even SCPJ, if you see renal transplant is one of the most robust in the country, and that's part of urology. But I think one solution could be that you have a separate dedicated unit, liver transplant unit, separate from routine GI work with its own theaters, own floors, own residents. That is possible. And GI surgeons can help. I mean, they'll be better trained, and so that is the solution. The existing thing, and it works. At least it worked for us.
So these are the few examples that I found in literature and some print media. So I like to discuss. This is one of the ILBS model. This is their deceased donor transplant experience that they have published. Of around 4 years, they have done 36 deceased donor transplant. And this is their model. They charge around, according to this article, they charge 11.5 lakhs to the patient. So I would like to ask Nihar sir, do you consider this as a pure public sector model, considering the geographic and commercial location of ILBS as well as the financial model they are into?
ILBS was purely, it was constructed to be focused on liver and liver transplant. Later on, they went into kidney and all these things. That was a separate, that was never in the mandate. So it was always liver, liver, and liver. So it becomes focused. So that's what, if I am a GI surgeon, I am not trained in liver transplant. I am trained in GI surgery, which includes Whipples. So that's my job, I have to do. So if I am doing something extra, and if nobody's there to take the responsibility, I am given added responsibility. So I will do for a month. That's what we have seen in SCPJ. First case, 20, 30 people, second case, 15, 10, and finally Dr. Rajan and me. So that's what exactly will happen to you. How many days you will carry on with this tension? Yes. Theoretically, yes. Practically, I have never seen it, never happens. That's why it goes for a few cases and drops. Many people have tried. It is theoretically possible. This government is serious about it. All the programs are now. So we are discussing why it hasn't picked up till now. These are not there. Things are improving. They are encouraging. They're getting more and more meetings done to improve transplant in government sectors. But best is this ecosystem. What is this ecosystem? Make teams, make centers, make units, make the person accountable, take proper faculties, train people. It will pick up. No question about it.
Yes, even doctors, they have some for some.
Yeah.
That is also. It's not just.
It's not doctors' incentive only.
I mean, indirectly.
So
but they do it.
So that was a more of a sarcastic way of speaking from my side to give incentives. What I meant actually is they have to be focused. You do esophagus in the morning and think of doing a liver transplant in the evening. This is how many ways you can focus. Then you have to neglect one, and everything is important. You have to, at the end of the day, our gastroenterology when we ask for a acute pancreatic necrosis to operate, we always keep it in the emergency. So one day in a big forum, the HOD said, how come it is different? Liver transplant, one patient. Acute pancreatic necrosis, one patient. So ultimately it boils down to one patient. So if it is one patient, by the rule of the constitution, everybody has to get the same attention. See, that is there. You have to pay attention to all the people. So it may be 10 hours, it may be 2 hours. Attention is same. So with these 10 hours, another 10 hours, I'm unable to give any attention, pay any attention. So I have to have a separate unit dedicated. That's the ecosystem what he is speaking about. Everybody has to be starting from the sweeper. That's what happened in Vedanta and Apollo when it started. What did they do? There was continuous failure. So what did they do? They took the entire unit, through the sweeper, everyone, the sister, the attendant, to outside, all the team get trained, reverted back, returned back. That's the
Another abstract from Stanley Medical College. They've done around 92 liver transplants in around, I think, 15 years or so. And they've also shared that this is difficult due to limited availability of donor organs. One of the major challenges they have quoted in the abstract. This is one of the print article I found that in Kerala, medical college hospitals have done around 11 transplants in a span of around 4 years. Still, it's come to a halt. We have Abhijit sir with us. Sir, would you like to comment about your program and okay, so just I'll after this.
Run through them.
Okay.
We started, I think, way back in 2013. And in fact, not many of you would be knowing we were not even a transplant center, not even a retrieval center. So the first
PPT.
Liver donation was brought from KGM to SGPGI, and even the recipient was brought from KGM to SGPGI, and both donation and the recipient surgery was done here. That was way back in 2012. So we still are struggling, I would say, and we began in 2013. But it has been a very difficult journey, but there have been some good stories and some good lessons to learn. Just quickly. So we got, we started by having mandatory brain death declaration in 2013. That was a very strong vice chancellor we had from AIMS, who himself was trained in liver transplant. He had a fellowship, Dr. D.K. Gupta, and he made it mandatory. We have over 13 ICUs. All ICUs every day they have to declare whether there is a brain death or not. That was as a rule. So it started with that. And then 2014, we were given the permission to start retrievals. And we started with that. Initially, 2 years, it was very good, actually. If you see, we were a retrieval center and we gave organs till date 60. But at that time, in 2 years, we had almost 24 donation and organs were given to SGPGI. First 5 went to SGPGI. Just skipped through RNR, ILBS, everywhere, So that's the green corridor and all just established. So we actually published this, and it's a very good publication. We have, out of the lessons which we learned from our initial 29 donation, actually no difference in literacy. There was a difference amongst religion, but it was a very good sort of experience which we had here, and we published this experience, and that was the prime time of donation at KGM. And after that, it has just been coming down. So then we got a license on 2018. So see the lab. 2013 we started, and 5 years, after just 2 or 3 inspections finally. And then this was Dr. Gupta who helped us from Max to get our first liver transplant. That was 2014. And then we got 2019, February of 2019. And then COVID came in, but we still continued. We had to do actually in COVID. But after that, everything stopped for 2 years. Next. So no transplant for 2 years because of COVID, and then we restarted in 2022. And then this was again a very famous politician, who got an organ in Lucknow, and Dr. Gupta had to come from Delhi to do this. This was on Diwali day. I still remember, and we did a lot of donations again. We restarted actually. It was an entirely new effort by us, and then we did the first combined kidney and liver. It all continued, and then 2 per day. This was a live and a cadaveric donation in 1 day, and a transplant in 1 day. Next. And then 25 transplants. That was an effort, was paid by us, and subsequently it got halted. Next. So till date 40, in fact, now it is 46. So majority, as we all know, were living donor. 8 cadaveric. Out of this, last 3 were sort of independent. So this is the highest number in, at least in a government setup in this state. Next. So now see this, majority was all supported, we had this Asat card, university itself used to fund initially, 10 firmly self-funded. And the cost is, as you mentioned, around 8 to 10, between 8 to 10 lakhs. And then you have this Deen Dayal Upadhyaya scheme, which is much like other schemes in other states like Rajasthan, and where we have a lot of government funding, but this is only for state government employees. But majority are poor, and just go ahead, I'll just tell you a lesson. This you already mentioned. So this is the timeline. See, initially we had 29 donations in about 2 years, which resulted in first transplant in 2019, 2 years hiatus, no transplant, then again we restarted, and majority were of course live, but we still had cadaveric donations. But now last 2 years, in last 6 months, there's one donation. So it's so these are the challenges. Much of this you've already mentioned. Now, these are our conclusions. Now, one important thing which we had, initially, go back, just one slide. All this we already know. Go back. Back. Yeah, this one. See, so, to make us financially independent, we took help of NGOs also, and we had a fund created especially for liver transplant, which is known as KGM Liver Transplant Fund, which gave us maneuverability to help not only patients, to even call surgeons and, incentivize also, sort of through this. And in fact, one of our vice chancellor made it mandatory for paramedical staff that they would get some amount, which is around 3,000 rupees for paramedics, no, not for doctors. This was official, but again, it was struck down by the subsequent vice chancellor. So now, no incentive. Right. One important point, as you mentioned, donor health card, which entitles the first skin of the donor family for free lifetime treatment. That is important, health and organ donation. And the other important thing which which helped in donation is on time, on table post-mortem. Because majority of these donors in trauma center level, which is the maximum pool for organ donation, head injuries are there, and they are young donors. That's the important thing, young donors without any comorbid conditions, head injuries. So they are supposed to undergo post-mortem, and for that it's almost 12 hours. They have to go to the mortuary and wait for forensic people to come. So we made it mandatory by the help of the district magistrate and our executive council that will be performed immediately on table. And when we used to explain to the donors, that as it is in post-mortem, your body has to be cut and lay opened. So why not you get it done here, on table? So that was also a good thing,
Yeah.
for us to increase the transfer.
Let me also-
Incentives, as I mentioned, we start. This is what important. That's it.
So, slides been changed. I just like to share that, sir, I was also the part of first living donor liver transplant at KGM when I was a part of Max team.
So that was help, So
yeah.
initially, if you have any mortality, everything will come in newspapers, and your initial program, your nascent program will come to a standstill. So you have to have a help payment.
TD sir, your experience?
I'll share whatever I have to say, because I still feel first we have to show the result, then we can think of having more and more infrastructure. The basic thing is that Dr. Viju is very correct in saying that if you have only one, made for only one thing, that you have a liver transplant or organ transplant setup, so everybody is, why they are getting salary? Everybody will be doing the same thing. The infrastructure will be, but that is not going to be so easy in coming future. But certain things, small things can be still improved. And mostly at the local level, many things can be done. And government level also many things can be done. But what I mean to say that in a government setup, it is most of the mindset which is responsible. So if everything is correct, we can do. Otherwise, if you are waiting, it will take some 10 years to have a big center, especially even in GI. As you said, GI and HPV and liver transplant is a good idea that if you have it, by the time you are having a slow progress in the liver transplant, HPV will support, and HPV is always supportive in techniques and everything. So you are doing liver resection, you are making more liver resection doing in HPV. Suppose you are doing only liver transplant, you might not get liver resection for the SCC. So all those things will contribute and make you technically better person, and you can do better things. Better infrastructure will be there. So that is not that is not going to stop. But at present, these are the small things which are, I think, the responsible for the donation down. Everywhere donation has gone down except this setup. So we have to look into why donation is going down. That is the very important thing. So I thought about all these things, that these are the reasons for donation going down.
This is our own experience. We have done around 27 liver transplant in a span of 3 years. Not so great. We have done around initial 8 transplants with ILBS, and next all the transplant have done independently by our team. So next thing is sustainability. So I think already Nihar sir told that we start and we do good for some time, but why we are not able to sustain? Why we are lacking in sustainability? So your thoughts?
Points. So I think if you summarize all of our points, that would suffice to answer why it is not successful. No. आइए मैं अभी आपको बुलाने वाला हूँ Now, see, all of us from our journey, we might be little bit cold by this time after all this experience. In the very beginning, we were very, very enthusiastic, all of us, to do the transfer. And why it hasn't? So obviously, all these factors have played their games. That's why, if suppose I am the director and he used to ask me, say, I'm giving you full power, 1 साल में ट्रांसप्लांट करके दिखाऊंगी सेंटर मेरा अप्रोच क्या होगा मेरा अप्रोच ये होगा कि every month I'll call the GI surgery team, they'll form a team of GI surgeons, microbiologists, pathologists, everything. I'll call the audit, answer me why this month this was not done. That's exactly what I'm saying for leadership. The leadership has to be there, that I've taken, this is my aim, this is my target, open it to the faculties, the HODs, every month answer me where was the problem, correct it. 3 months, enough to start transferring any government center. Tertiary care. So those are the points which we have already discussed. I think we can go over to the next point.
One point is, sir, whenever there is a failure of any case like mortalities and the news spread across the hospital, across the system, does it impact the ongoing program?
No. From my side, from M side, we have analyzed it very carefully. We have published on this also. It doesn't matter.
Especially when you're doing very limited numbers.
Of our population, of our patients are poor. We have tried to dissuade them. Let's see, if you get a transplant done, they will come. Here, I want a transplant. My brother is there to donate. After that, what? So husband is doing thela and wife wants a transplant. So how do they manage? See, this is where the things stand now. So even if you say, see, you may die, you may do all sorts of, they will say it's ambiguous.
Biju sir, do you?
Mortality does decrease the donation. If your mortality is too high in a year, then in your group, in the faculty group, in the intra-departmental and interdepartmental, there is a discussion going on.
Yes.
There are somebody, there is a cake for the food. I said immediately the referral department start thinking and they start referring to the affordable patient to the setup who are doing
Exactly.
better transplant service. So we have to be very careful in our statement because even the hepatologist will not refer once 1 or 2 continuous mortality is there. Hepatologist, the moment he gets an affordable patient, he will refer to ILBS or Medanta or anywhere. He is not going to refer to the same patient. So it creates even in the staff nursing, even in the anesthetist, it creates a mood of depression that results are not good. So we have to try to have a result which is not even if not compatible to what is established center, but at least go close to that. So if you are a very high mortality, it is going to decrease your donation. Very important this is. And that donation, they all will think that itna to 3-4 hua sir, mar gaya to.
So you see, and the other important thing, which I've faced in public sector, setup is that you are viewed differently by these news person. Any news is much more amplified when it comes from public sector, especially the negative news. And in the private sector, they are very well managed. They have their own HR team. They will manage everything. Even and they'll blow out to proportions the positive thing, and the negative things are really just scrapped. And we as a government sector, like we had one donation, and the recipient died. And it was all in news, And if something happens in private sector, it's all very well managed. And that affected our donation. Then the TD is right.
Will you say your words?
Little bit different with the Dr. C. We will not should not get an assumption that subject expert coming as head of the institutions will change the scenario. Okay, it will not happen. We had 4 great institutions headed by
Hepatologist.
gastroenterologist, hepatologist, surgeon. None of them changed the transplant scenario in their institutions. This is the fact. Okay, so this transplant scenario is changed by people who are not subject experts, including your institution, include the institution, whether it is AIMS, so that is not the actual, probably the.
I didn't say subjects. I said the director has to take the responsibility and leadership. Why? The minister is not a subject expert. Why he is across that transplant program? I am saying the director has to have an audit every month with all the heads who are responsible. Answer me. How many you have sent to private hospitals to take incentives? Why this many people are not transplanted? How many organs have come out of the trauma center? Why they are not been? What has been your corrective measure for last month? 3 months. I tell you, 3 months. And we had seen that change, and that change vanished after 3 months. When the coordination between the neurosurgery and DA vanished, everything vanished. So not at all. Subject
I think the organizers have asked to close. Your final comments, sir? Anybody? Final comments? Like, what should be the future? Like, if we had to take the transplant ahead, especially in institutes.
You should have a dedicated, given that one. You should have a structured program in place with fixing accountability, and there has to be a system of incentive. You do surgeons also. You have your surgeons get trained, and then they just fade away in terms of monetary things, by private sector. So the multiple things, you have to have a multi-pronged approach, and it will work. And then many of these patients are not as demanding as private sector. So there is hope. I would say there's hope, and you have to strengthen category collection to the strength of.
Okay. Thank you. Thank you very much for all the panelists for joining this panel discussion. And of course, I thank my alma mater and of course, Anu Bihari ma'am for providing this opportunity. Thank you, ma'am.
डॉक्टर अनु को कुछ बोलना था, आपने बोला नहीं कुछ.
Because I wanted these things to come out. We never talk about it. Like it has been happening for so many years, and we never see why is it not happening in this culture. All these things. So I wanted things to this.
पहले उसको लास्ट मिनट कुछ नहीं ऐसे बुला दो.
I was also associated with transplant program very and the CPI. So what I understand this can even from the literature, cause of failure liver transplant is many. It's starting from the government and then it goes to the financial stability or provisions of the government. Secondly, to the institutional administration. Then it goes to the leadership issue, it goes to the coordinator, it goes to the nursing in charges, it goes to the interpersonal necessity, it goes to the interdepartmental necessity, ego and claiming, self-claiming for everything. What though it's a teamwork, like you mentioned. And last you have mentioned you have several audit in various parts of the country, several accounts, and you have come to conclusions. I think it is failure in any institution has multiple audit, despite multiple failure, all of you sitting from the institution, and multiple audit, it's still failing again and again. So what is the solution? It's not audit. You have a different concern of finances. Somebody has a concern for coordinator. Somebody has a concern for government. So there should be some solution, and it's coordinated. So I feel every institution has a different kinds of problem. It's not anonymous and one problem, but there are multiple problems, but not specific to one institution. And audit has been done, so you should not fail to rectify based on the audit and take a corrective measure.
So those are retrospective audits. We need prospective audit.
So after long years of discussion, the NATO came out with the first document to explicitly say that in institution, specialty departments or divisions has to be created to advance the transplant program. This is one very clear statement not as given to all the statements. This is the first time this time. Not has also come out with a second statement saying that the centers of state governments and central government need to establish dedicated transplant centers across the country. So these two statements are now very clear. The policy is more or less very clear. So the message is what we are trying to communicate. Let us stop struggling with the existing departments and let us stop trying to find out the solutions within them. It's not going to work at all. And we have tried it for 25 years plus, it's not going to work at all. Let us say there is a liver transplant department or liver transplant surgery in IITs, liver transplant surgery in Vedanta. It can be easily replicated in AIMS or other centers. It is possible. PGH Chandigarh is a department of kidney transplant surgery. It can be easily replicated here as well as any other centers. So we have models. So this is the only way. Otherwise, what we are trying to communicate is we'll try to discuss the problems in the existing department, which is not going to work.
What I think is possibly you have mentioned rightly, those are also a concern about like a GI surgeon cannot do everything because if you are overburdened with routine GI work and you are not specialized training in manage pre-operative, pro-operative, and all the aspects of transplantation program. The best would be if you have this either in a separate transplant unit within the department and people dedicated only for transplant. If you want to do hydrocephalic hernia and transplant all together, you cannot succeed. It would be likely to fail. So one is this, and obviously I have already written a this paper on this. What is the future of subspecialty of GI surgery in India, published in year 2024 in Indian Journal of Surgery, and we needed separate subspecialization of the GI surgery to sustain for longer time. You can sustain for some time, but you cannot sustain. And we have to prepare for the future of subspecialty, which is the coming way, the root of technology and technique and expertise. Now the era of technology and tools. The skills are only a part of it. So we have to gather people to succeed all these. The subspecialty is going to be come up in the name of liver transplant. That would be the solution. Some expert, obviously, the leadership issue, ego issue has to be solved to succeed in such transplant program.
One final word for the notice of all our SCBJ people. Dr. Viju has been quite modest. And being from Kerala, there is actually a big project which is envisioned by the government, and of course he has been behind this. It is actually the initial steps have been laid, and the Bhumi Puja and all is over. Only thing is, all this is related with some politics also, but the concept is very correct. As Dr. Viju told, it has to start, it has to be born as a transplant center. It cannot evolve. Like I was from Jipmer and I served 4 years there. It is a general surgery place, MS general surgery, MBBS. So to evolve from MBBS to MS itself, there is a big difficulty. They just finish it on time. So it has to be born as a transplant center, and that in that situation to definitely succeed. So being my senior Biju in SCBJ, and also I had the opportunity of working with him in Jipmer, I express all my wishes, my prayers, and as faculty, one of the faculty and colleagues from SCBJ, we pray that your center will be a great success. And we all are behind us, behind you with our minds, hearts.
Director of that transplant.
So that is what is called leadership.
Yes, practically president elect of ISPB Indian Center because there are no opponents.
Punjab, one center in Punjab, PILDS Mohali. It was established say around 1.5 years back, and they've already done one transaction. It's only for hepatology, PILDS Mohali. Finally, it's point is very right. That's point is very right. That's only a center which is for transplant will have the accountability.
We want a center for the transplantation. But why is the discussion of linking it to the HPV? Every time I see, that is a hesitation from a surgical gastroenterology unit as well. That is something because of which we see lots of resistance. What is the reason to link it to pancreas or biliary system? Why can't we have a transplantation unit or a department or a center for transplantation only? Probably with this only we can move forward. There will not be any conflict and patient those this specific area can be looked in and there will be focus on liver transplantation.
Transplantation separate specialty altogether. You are a 50% plus gastrologist, other surgeon. You don't need HPV surgery fully. The problem with linking HPV surgery is suddenly the pancreas will come. The pancreas picture comes, then the whole ecosystem will get spoiled. You can't discuss one patient with the pancreas here and liver there because there's a totally different organs.
Or in the fact, if somebody says transplantation would be required in the CLD patients where hepatitis can be an option, and that should be a reason. So that liver while biliary the pancreas system. There should be a separate unit, or can we make a separate subspecialty?
If you go to the verticals in Western system, you do not have surgery as for that. General surgery, then go to pancreas surgery, transplant like that. So you need not go to surgery to HPV surgery and transplant. This is not a vertical. This is a very unscientific vertical.
Sir, medicine like Western area and South, East, they have units of liver, biliary system as well as pancreas all separate.
No, see, it's actually, if you start doing liver transplant, it's all about you want to do it regularly. You cannot be a pancreatic surgeon. It's as crystal clear on that. You cannot operate on carcinoma of gallbladder. It has to be left to the oncology people. You cannot do aggressive liver. This is a totally different ballgame altogether. You need to know immunosuppression, liver failure, volumetry. This is there in your mind. In that, what is the TNL staging of gallbladder cancer? You should not know.
Why should we?
Yeah, that's it. You go on connecting, every organ is connected by blood.
So why?
In one of the big institutes, it's the Department of Endocrinology, Surgical Endocrinology started when there was
नेक्स्ट सेशन है क्या मैं क्या वीडियो
transplant into liver transplant, not chronic pancreatitis, cirrhosis, everything. So you have to define your margin, your area. That is very important.
In the current program of ILBS, what they say it is HPV and transplantation, where they think and they show you that pancreas is a part of their curriculum.
No, please go to the original document of original faculty advertisement of SPD. So two faculty, two departments, Department of Liver Surgery and Department of Transplant Surgery. This is the two departments. Because the institution of liver and biliary sciences. It had nothing to do with the pancreas. Okay. That was the advertisement of the but now kidney also. Now this is the so when you try to take original ideas, it is going to take its course. ILBS is 20 years plus. The numbers are close 100 now.
अच्छा
You should have been close years back.
नहीं अजीत सर है
So the
अजीत सर
then it is going to be so the concepts were very clear.
उनका नाम नहीं पता
It was never an HPV center, right? With the liver and biliary.
Like in a CPT, the hepatology unit or hepatology department, which has been opened, the syllabus says they have to know pancreas as well. They claim that we treat pancreas because that is in the syllabus of hepatology.
Director schedules
बोल क्या उनको? You go to Leeds, hepatology, transplant today. It's only liver. Okay. There is a way. So we need not reinvent the wheel. But that has been well said.
बोल क्या
Very
उनको?
honest.
Please not say
Just
this.
the
बोल दिए.
hepatology department, SCPGI, they claim that pancreas, their syllabus, they read and they teach about this. And they want to treat all those pancreas cases as well.
ठीक है थोड़ा ज्यादा पढ़ लिया क्या हो?
That creates a conflict among other departments actually.
तो कोई conflict कुछ नहीं है वो तो if you have a good number of liver transplants and join attach pancreatic transplant to that, you won't have any time for very yourself to complete. अभी some mess चल रहा है. I was selected as the associate professor of liver transplant. I actually said that you will do only liver transplant actually. What can I do? Can I do not a single transplant has been done, and I will do liver transplant only and nothing else. What can I do? So I have to take. So that's what Todoroki came here, and Todoroki said, and Hanks, Professor Hanks came this. He said you should only do liver transplant. That was 10 years back. You should do liver transplant only if you do at least 22 major liver surgeries a year. So वो concept था अब change हो रहा है. If you have a big area of coverage, automatically obviously
I just want to make two comments, sir. This extensive discussion has been discussed a lot regarding cadaver liver transplant, but in private sector also, the government sector really wants to scale up the liver transplant. I think personally the only way forward is living donor liver transplant, because
That's what Dr. Rella says.
even though technically it is more challenging, but logistically it is a lot simpler. It's an elective surgery planned and can be done at the appropriate time. And one more comment is also regarding transplant hepatologists. Even though there are a lot of hepatologists, what we see even in private practice, even the hepatologist doesn't refer the patient for transplant at the right time. That is also a critical thing. We need to have a good team of surgeons and a transplant hepatologist and a dedicated unit as about discussed previously. And living donor liver transplant is the only way to forward if you want to really go on the level of transplant being done in the government sector also. You need to just develop personnel and all the equipment and infrastructure needed. That's my opinion. Because cadaver transplant, still there is a railing thing, still we can't go beyond a limit per year or per month. But with living donor, we can go as much as the department can.
Okay, at least big hand for Dr. Anu to start all these things here. I think it is YouTube transmission is there.
Yes.
So it must have reached the government. Wait for the next thing.
Thank you so much, sir. It was a beautiful, engaging discussion. We move on now to the next session. I would like to invite the chairpersons, Dr. Ashok Kumar Jr., Professor, Department of Surgical Gastro, SGPJ, Dr. Supriya Sharma, Professor, Department of Surgical Gastro, SGPJ, Dr. Kaushal Anand, Director, Sharja Hospital, Ahmedabad, and Dr. Kailash Purdia, Faculty from Department of GI Surgery, AIMS, Delhi. I would now hand over the stage to our first presenter, Professor Dr. Nihar sir. He'll proceed with an interesting patient story narration.
So I think it is for 5 minutes, isn't it? So can I start?
Yeah.
So this is an example which again emphasizes my version that if you mix up transplant with others and put a lot of mind to different places, you lose your fundamentals. So this is one of the problems with one of my patients. I'm presenting it with the permission of the patient and the family, and I will be showing the pictures also. Please don't mind if you feel otherwise. चल नहीं रहा है. इसमें नहीं चल रहा है. With due respect for the patient, she was a 56-year lady, wife of a retired person, was staying happily in Delhi, West Delhi. In 2013, they were planning to shift to Canada. Her daughter was staying there, and she developed cholelithiasis and cholelithiasis symptomatic. ERC was attempted, cleared, and then the doctor said, please get it done, the surgery there. It would be difficult for me to manage here. So a cholecystectomy was done and CBD exploration was done. It went wrong. Bile leak, everything happened. And then they called a oncosurgeon nearby who was operating in another OT. He came, he excised the CBD and did a hepaticojejunostomy. The patient went on to have continuous episodes of cholangitis practically over next 6 months. And in the meantime, she had pneumonia, sepsis, ICU stays, antibiotics, exhausted everything. And this lady who is on the left side was brought to us in this situation to AIMS after more than 6 months. So when she came here, is there a pointer? As you see in the MRI pictures, there were densely inflamed biliary tracts, cholangicular abscesses. This one. So, yeah. So this was the pre-surgery picture, and then these are thick-walled bile ducts. And then there was a pouch-like thing at the lower end of the anastomosis. This was a dilated proximal end of the jejunum. This is again the dilatation, and CT also showed a dilatation. And she was having frank episodes of cholangitis. So we thought possibly there was a rule limb obstruction. So we explored this person, and we found that this was the duodenum, the afferent limb like this, and the person had done the anastomosis here and joined this part to here. So obviously we wanted to convert it into a proper Roux-en-Y. We opened through this area, did a cholecystectomy. It was going well into the ductal system, so anastomosis was very well patent. So how do we convert this one? After 40, this was 30 centimeter. After 45 centimeters, we divided it here, we divided it here, we joined to this, and we joined to this one to give a Roux-en-Y configuration, like this. So for about for 15 days or so, the patient remained okay, and then continued fever post-operatively with episodes of cholangitis. This continued for about a month or so. So we did MRI, CT, and found almost similar feature. It was there. But the drain which was put through this was draining bile as well as muddy fluid, indicating that there was some mucus from the jejunum also coming through, which is expected. We did a PTBD along with this. The PTBD also started draining similar type of material, bile mixed with muddy fluid. But the patient continued to have cholangitis. We did a nuclear scan. We showed that there was beautiful uptake, and there was even good excretion into the intestine. But there was a hold up for some time, quite a good amount of time, means about for half an hour to 45 minutes before all these things started draining. And CT scan again showing the similar feature. There's something hold up in that area. So again, 3 months passed by with this conservative management. And then after that, after a period, we did a tubogram. Since it never improved, we did a HIDA, we did a CT scan, and it was same finding, the similar pouch-like thing here. And then the nuclear scan was almost similar picture, but things were going down, but with a very wide transit time. And then we thought this is high time. Let us give her a last chance for exploration and see what is happening. Maybe dismantle this thing again, do everything again like that. So we opened up the abdomen. What we found was that this was the initial configuration. This was the configuration we had done. And when we opened, we didn't find anything. We did a scopy again through these all same finding. There was minor dilatation of the limb. We did a opening here, again did a retrograde scopy. We found nothing. There was no jejunal obstruction, but we left it for some time. Then we observed the patient for about 1 hour or so and came back thinking what will be happening. What we found that this was the hepaticojejunostomy site. This was the jejunostomy site. So I had gone for a coffee outside. And my senior resident, he said, "Sir, I am finding the peristalsis going from here to here towards the hilum." So we observed that this is actually a video. So it showed peristalsis going from here to here almost every 5 to 6 minutes. So we had no idea what was that. There was nothing in the literature. We searched in the literature, there was nothing. So what we decided is this was the configuration. We thought that initially this was the afferent limb, this was the direction. We have left behind this one. So that's why the peristalsis is going like this. So we completely dismantled this, and then we completely resected this one and threw it out. And then did a Ru and Y properly, like cutting here, then joining this one to this. And then after 45, then we did a jejunal anastomosis. So basically we resected this limb out, and this was the picture. So after doing this, the patient started improving, the complete improvement. And this was you can see the very beautiful flow into the jejunum. And there was minimum postoperative bile leak, and the patient was moribund. So took time to improve and was discharged after a month. And this is the after a regular follow-up. All tubes were out, was back to normal activities. And this was in 2013. This was nearly after 1 year. This is 2026 when they had sent this picture from there, and they're living happily with normal everything. And this was their testimonial. So what was this? It was actually a case of reverse loop syndrome, which came to picture to article 3 years after we operated this. So we wanted to publish this. We presented in our CGR club, but people said it could affect the primary surgeon. They has done a wrong thing, and this is the consequence. So better not publish this one. But we got a publication. We saw the publication from outside, and this is what they had described. So this is a reverse loop syndrome. If you join the afferent limb to the duct and then do the anastomosis, you can find this one which was not there. So the bottom line is, after that we started searching, and we had 19 type of ruling problems. So a month back, Dr. Kapoor had given me a chance to speak on ruling problems there in JSF. I discussed, and I say most of our juniors or students, we never teach them about ruling. And they think it's just a tube to conduct the bile from here. It is a functional tube. It's not a structural tube. There could be many problems which we do not really record when we re-explore the patients. And this ruling problem can cause leakage of the primary anastomosis, be it in the pancreaticojejunostomy, bilioenteric anastomosis, even gastrojejunal anastomosis, jejunostomy sites. So we have to teach them very clearly what should be exactly be done, how the openings or the masonry defects should be closed, etc. So that is the bottom line of that, and this is about this person. Thank you.
Getting very strange kind of case that reverse peristalsis can lead to the stasis of the bile, even the cholangitis and multiple problems.
No, we think we say some books which write that these are dead limbs, like there no peristalsis, nothing. Then I found in literature that there are enough animal studies. Even the colon which we are pulling, that is not conducting by gravity. That has a very good peristalsis. The rulim has a very good peristalsis. It has absorptional problems that we have to keep it in mind. The ulcerations, the fullness, all these things are associated. In the traditional, when you do it right also, the Roux-Stasis syndrome, right? You divide new ectopic swarm and the peristalsis is reversed, though it doesn't have much of increase in clinical practice. There's a Roux-Stasis syndrome also displayed, where the peristalsis is reversed, even if you make it properly. In this, of course, there's that case totally. Yes, Roux-Stasis syndrome is there, which can affect, but what was happening is there in Roux-Stasis, ultimately it goes down after some time. But here everything was purging into the liver. So bile ducts were getting infected time and again. The patient was in full-blown sepsis, even if the HIDA is showing normal, MRI is showing normal, tubogram showing normal, patient is having. So that was the thing.
My question to you, why you didn't exercise the index surgery?
The
You
idea.
didn't dismantle the loop because you might be knowing the action loop syndrome, the action loop syndrome, the stasis syndrome. So that is an unusual way to do, making an smooth the action loop.
Yes, absolutely. I agree. That's what I'm saying, that this idea was not in our mind. We also thought that that was a conducting limb. So it was conducting. So it was only published later that these peristalsis are there. This could be like that. Had we knew that one about the reverse loop syndrome, we'd have done that.
My point is other than sir, totally we don't make an anastomosis saying about they have done it. But technically they make a mistake taking an afferent loop to the biliary anastomosis. So at the time of reexploration, you would have dismantled the anastomosis, biliary anastomosis, then make a proper one.
That was normal. No? Biliary anastomosis was fine. We did a scopy. But the loop was also normal.
No, sir.
But
what you resected is affected loop. My question is, at the first time surgery at your center, you would have dismantled the anastomosis, remove the segment of the loop, then make a proper
that would have been the best treatment which we did as the next surgery.
Yes.
But only that was lack of knowledge. That's what I'm saying. At this stage, 2014, with this, we did a Roux-en-Y. So we thought see, this is a purely Roux-en-Y happening, but we had no idea that there would be reverse peristalsis even after this. So that was you can say it as a mistake and say that a lack of knowledge. But entire team was after this, what was happening, everybody was finding, so everybody said you make it a Roux-en-Y configuration. If I just show it this picture, you say it's fine, except that the peristalsis has a chance to go up. We knew that literature was saying once you do a Roux limb separately, because of nerve disconnection, there is no peristalsis. That's why Roux limb stasis occurs. So we did a Roux-en-Y, but this is what you were saying should have been done here. Yes.
So Avinash, at the time of the first surgery, here. Supriya. So at the time of the first surgery, did we notice whether the JJ was stenotic or not?
Yes. Yes, we did. We did scopy through this, no? We did scopy through this. We saw the anastomosis. We did through this. The JJ was fine. Again, we did it for the second time. The JJ was absolutely fine. And it was not so dilated like the second surgery. It was a little bit dilated. And finally, we have to put a tube through here, where we had done the scopy. It was very wide anastomosis. Very wide anastomosis.
So here, sir, we can see in this picture, we cannot differentiate where is the hand loop and the JJ loop or badly adhered. why this is not possible to get any communication between two loops and directly the fluid is coming in the end loop and causing.
No, we did a complete adagiolysis. So this was a video actually. I'm not. This is not playing here. It's a complete adagiolysis. The limb was completely clearly delineated, starting from the JJ to the root limb, and a scopy was done again through this after dismantling. So it was all fine. It's only we could the picture if you I am having in my laptop. It's very clearly going like this, which I showed in JSF.
Thank you, sir, for the wonderful situational discussion. I never thought this will exist, but this is for the first time listening to such an entity which is happening. One similar quick comment. One patient, I heard about a story once under a high police GSF in Kochi, routine periambulary vapors. Every time the FJ was started, the patient was getting bloating, sweating, the abdominal discomfort. But oral intake, no issues. But every time the FJ is getting started, what's the problem? Finally, they did an FJ graph. The tip of the tube was towards the capital, to the bile duct side. So we never thought such an entity will happen. The FJ tip should be towards the distal, to the distalmost anastomosis. So it can potentially happen. To avoid such technical problems during surgery, Dr. Avinash, the professor of HOD, one of my mentors in the government medical college department, he used to say, there is only one difference between general surgery and gastro surgery. In general surgery, dissection, resection, and reconstruction. In GA surgery, one component is added. Loudly, clearly, every time we do, even if we are doing the same surgery for the 100th time, we do something known as dissection, resection, discussion, and reconstruction. That's an important point. That's an important point because the tail end of the surgery will be finished by the residents who are exhausted by yesterday. They are exhausted already by yesterday's 24-hour duty, but it's very important. This is not now. This is the thing which has to go on. Every time we say it like that. Thank you.
I just telling yesterday, this was the thing a month back not month back, in August, I told many people, August, I was explaining my residents, I was operating and scolding and saying everything. Then I joined and I found I joined the proximal one with the, this is in August that happened. I have the video.
Thank you, Dr. Nash, for a very interesting, thought-provoking case presentation. It stimulated all of us. Thank you so much. So for the next presentation, can I call upon Fali Krishna, please?
So my memorable case is not as perplexing as Dr. Das case, but it's a frustrating case. I mean, some of the patients, all of you have roller coaster cases in your life, but a roller coaster should last like a couple of weeks, maximum couple of months. If it goes on for years and years, then it becomes a very memorable case. So this is a patient of a hyalocholangiocarcinoma, 65-year-old guy. Obviously, that even for so many years has been an area of passion of mine. This is a type 3A hyalocholangiocarcinoma. He came in. This is this PTBT CT scan. We did a left PTBD we did, and a right side portal vein embolization we did. So the first problem, I mean, I'm just like events. How many? We had a lot of events. So the initial event was obviously you done a PTBD, but some sepsis got introduced in the right side systems. Persistent fever was happening. We decided to control the sepsis. Bilirubin came down, but it was continuously spiking. So we decided to bring down this thing, but we did a right anterior and posterior PTBD. Then he went home, again came back with fever. His LFTs were normal, but then it was a COVID era. Obviously, COVID was tested. Then he became COVID positive. So at this point, he actually became not very sick, but he was on HFNC for a couple of days. Improved, and by 5th, 6th day got discharged. At that point, the big dilemma for us was in COVID, there's a report of prothrombotic complications. And in the right side portal vein resections, almost 50% of our resections, we do a portal vein resection because the bilum is to the portal vein confluence if it's stuck. So if there is portal vein thrombosis, should I operate or not? But the other way, external PTBD catheters should be very careful because if they get dislodged, which very commonly they can happen just in the patient, if they're internalized, it's okay. But if they're external,
just mild dislodgement, there'll be a biloma, sepsis. And I know all of you must be sharing that most of the hyalochoangiographies, especially if you do ARCP and even if you do PTPD, they don't actually reach the operating table because of all these complications. So I thought about a lot, and after 4 weeks, I thought, okay, 4 weeks later, patient is better. We bite the bullet, balance of between waiting and not waiting too long, we did the surgery. So I did the surgery. We are in private practice. We take permission of the patient. After the patient gets discharged, we put the success stories. Yes, this is this patient, high local angio, but with COVID positive. In the COVID era, despite this, we did this and others. Then patient went home. Of course, this was the surgery we did. Surgery went smooth. Got discharged by day 7 or something like that. Patient was obviously, you can see him by the time with all the sepsis, fevers, then COVID. He was a bit frail, not too great for the operation, but we decided to go ahead because, again, we had 3 catheters hanging out, and that's always a dangerous thing. Then the worst thing a patient, doctor can have is this experience. I'll tell you, at 12:05 in the night, we have private practice, we give the number to the patient. So I get a video call, and patient is just lying with absolutely, he could be dead or he could be in syncope, absolutely expressionless. So do something, do something. That guy lives around 60 kilometers away. So I was like, okay, this guy's got some hypoglycemia or heart attack or something. I didn't think of any surgical problem. So just get him quickly to the hospital and get them to call me. So I went to a neighborhood hospital. He revived. It was a syncope attack. After IV fluids, he revived. His hemoglobin was 6. So immediately we thought, okay, it's a obviously pseudoaneurysmal bleed. Whether it was he didn't have any sepsis or biloma, bile leak, post-op, anything to indicate such thing. Is it some technical issue or is it was COVID a factor? I was wondering. So we did with getting him across was obviously you have a high local injury ruptured. You don't want the patient to die en route. We did something. We sent our registrar halfway there. The ambulance came. Then we transferred, got him, and we could salvage that part. So till there, okay, it was okay. I mean, like thought sort of success story. He immediately improved by next day, a couple of blood, and he was better. Then this big problem started. 2 months after, 1.5 months after surgery, patient developed tense ascites. What obvious thing anyone thinks of is gross ascites, your portal vein is gone or your hepatic vein is gone. Or post-hepatectomy liver failure. These 3 are the possibilities, early post-op. So his LFTs were normal, his platelets were normal. Actually, his recovery from surgery was brilliant because there was a portal vein embolized patient. Ascitic cytology was negative. We did the CT. We did the CT. There was no evidence of portal vein thrombosis, hepatic vein thrombosis, graft. This thing was good. We also did the HVPG. In fact, we because patient already by then finances were dried up. I said, okay, let me get a HVPG done. I got it. That is also normal. At this point, it was a transitive, but at this point, obviously, if there's no obvious cause for the liver ascites, the common thing is, yes, patient COVID, delayed surgery, all these are immunosuppressive patient, he's had a florid recurrence. So our medical oncologist after me, I'll start him on palliative chemotherapy. I mean, I'll take to talk about the chemotherapy, but in a palliative setting. But for me, it was like, see, that in hyalochoangio, it's not a single disease. You have these scirrhous kind of cicatrizing hyalochoangiocarcinoma, is usually locally advanced. Then you have the nodular mass forming, which has an aggressive peritoneal disease. So I couldn't believe that a patient who had done surgery 1.5 months back can develop peritoneal deposits. So I said, one of the unusual things I did 1.5 months after surgery, I went to do a diag lab to look for peritoneal deposits. Peritoneum was normal. And not every ascites we found a cause. This is not the first patient in which, after extensive evaluation, we couldn't find some sort of a polycirrhosis. We don't know what that is. We just left him for the time being. Ascites spontaneously resolved over a period of 1.5 months, like that. It resolved. His at surgery, the tumor was as regular hyalochoangiocarcinoma. It was stuck to the portal vein confluence. Those kind of things. Normally, I would not think twice. I would just resect that segment of the portal vein because left portal vein resection is pretty easy. But because of the COVID, it was in my mind. So I just got it off, and I thought, I don't see in this the hilar. Many times your operative findings also dictate how patient is going to behave. So the biopsy came as CRM negative, but in my mind it is always positive. He was node negative, but perineural venous invasion was positive. So this is a guy who needed chemotherapy, but at 3 to 4 months, we had already too late. We passed the benefit fade. So we thought, okay, if he develops recurrence, let's give him palliative chemotherapy. So what this did, so patient recovered 1.5 years later. Then 1.5 years later, he came with so the gross ascites in his post-op, every place, the drain side, the wounds, the abdominal wall, everything had become stretched out, and all hernias. He had a huge hernia, and flank he had a huge hernia. So this was the obstructed, this hernia here, and a bowel loop had got stuck in it. Came with not a high grade obstruction. Obstruction got relieved, but we realized that bowels are getting stuck in it. So we, at that point, my decision was, should I do a, this entire abdomen was thin, skin only thin, and here there was a small defect. Should I do this whole thing, or should I just repair that? I generally, for my major surgeries, I would like to preferably never like to do another major surgery for the rest of their lives. Want to do minimum possible. So I thought, okay, let me just do the hernia. Unusual thing that happened is after this hernia, and again, at hernia, before the hernia surgery, we did a PET. There was no peritoneal deposit. He again developed ascites after this. Again, we reevaluated any hepatic vein, this thing, but okay, last time we waited it out. Again, it's spontaneously resolved. So this guy, every time we do a surgery, some sort of a serosal polyserositis reaction is forming ascites. We did autoimmune profile, everything turned out to be negative. Then obviously, by then, we had also entered the era of TAR. With this patient, we were going in eras, and so around 4-5 years later, this was the huge hernia he had in the midline. A big loss of domain hernia, for which we gave him Botox and did a subcostal TAR. So that's my story. So this is a patient 6 years later. So this guy doesn't get any chemotherapy, any adjuvant therapy. All these things went on, but he did very well. I mean, in the long run. So I mean, it's again, I said, like, not a very dilemma case like SIRS, but it's a very lot of events, some 8-9 events, like I showed you. What I feel I learned from this patient, one is, of course, all of us know hyalocholangiocarcinomas, the challenge is huge. And in patients, the road always feels uphill. One example I give to a guy is, if you're climbing upstairs, some like Tirupati or something, if you keep looking at the destination, it seems so tiresome. Just look down, look at each step. As you climb each step, at least the progress is much better. So in these kind of occasions, there was many times it was like really frustrating, and we thought we should give up. I mean, this guy is having the same thing, just send him home on this thing. But when if you take each step at a time, you can sometimes succeed. And when you have difficult cases, I think that's what you should do, and don't generalize. Obviously, like ascites, if there's no liver related, it has to be no amylase. Amylase is normal. Liver is not the cause. It has to be malignant ascites. It's common sense, but all of us know not everything in medicine is explainable by our knowledge. There's some things outside this thing. I think for lack of time, other things I'll skip. Thank you.
Very interesting case. What do you think? What was the cause of spontaneous aside formation itself?
I think, see, when everything is negative, you rule out chyle, you rule out pancreas, you rule out liver as a cause, malignancy, you rule out malignancy. You can have patients who have malignant ascites in which ascitic cytology is negative. You may not have peritoneal deposits. Sometime. So that was just like I mean, so if you ask me, the redux, when the hepatitis came 11 time, it's like some sort of a polyserositis related to some immune mechanism is what it felt.
Is you plan for the hernia surgery, I think, and that time also patient developed.
Yes. Again, he developed this. So that's one thing. Always, at least major surgeries, do your minimum possible. If that patient, I had done a TAR, in the post, I just went in, put a mesh and came out. Simple surgery, no chance of any ascitic leak and all that. If I had been a very aggressive surgeon and 1.5 years that I went in and did a big TAR and he developed the ascites, it would have been a miserable course.
Second surgery patient require any treatment for the ascites or not?
No, but again, we reevaluated this time. We didn't do a paradigm. No, only 2 times we did that.
So it would be some peritoneal reaction.
Polyserositis kind of thing.
The peritoneum.
Exactly. So we all of us, I mean, I'm sure not all ascites can be explicable. Actually, we do have cases in which every workup is negative. I'm sure many of you.
From the surface of the
yes, exactly.
In first surgery, definitely you test the liver and the peritoneum both. But second surgery, you may not have irritated the liver.
Yes.
You irritated the peritoneum only. That could be the possibility of forming the cell.
Yes. So that's the thing. I wanted to discuss some lessons from that case, but I think we are running 5 minutes of the time allotted. Enough.
Thank you. Very good evening, and first of all, I would like to thank Anuman for giving me this opportunity. So I'm going to discuss about one patient who had a disconnected pancreatic duct syndrome. As we all know that this entity is known where the ductal continuity gets lost and the viable parenchyma of pancreas will be drained in some pseudocyst or in the external fistula. So my patient was a 29-year-old gentleman, and he was admitted in multiple hospitals across 1 year. Almost 5 times he was placed with the both-sided ICDs before coming to our hospital. And his initial workup was done by pulmonologist, where he was ICD was placed, and the CT was misread. So this finding was mine, that because it was shown that there is an abrupt transition with the pancreatic duct in the distal part was dilated, but outside it was just mentioned as like finding suggestive of acute pancreatitis. So once he came to us, we evaluated him with the MRCP after stabilizing him, and that shows. I will show you the MRCP. So this is the MRCP that you can see there was a pseudocyst which is going across the hiatus up to the mediastinum, and in the coming scan you can see that the distal part of the duct is dilated and there was a communication with the distal part, and the pancreatic part which is the in the head side was the duct was normal. So the diagnosis of DPDS was made, and then we also got a CT scan at our center that also shows portal cavernoma. This is the pseudocyst. You can see clearly reaching up to the mediastinum, posterior to the heart, and bilateral effusion with underlying collapse of the underlying lung. You can see the entire abdomen is inflamed. And then there was a cavernoma at the porta. The portal vein was replaced with the cavernomatous transformation of the vein. Here also we can visualize the dilated distal part of the pancreatic duct. At this moment, the patient has already had suffered a lot before coming to us. So we thought that we can give a trial and we can try with the lateral pancreatic jejunostomy with intraductal drainage of the entire pseudocyst. The other option was to doing a distal pancreatectomy, but again, pancreatic preservation is always a priority if we can do it. So So we started with again, as Dr. Arun said, midline laparotomy with division of falciform and then opening of the lesser sac. So the lesser sac was again inflamed because of the ongoing inflammation. The duct, we could see the bulge there at the site of a duct, and so that was confirmed with the aspiration. And then it was opened with the cautery, and then you can see how the fluid is becoming dark and it is being drained. Then the entire pancreatic duct was opened along that line. So at this point where the right angle is placed is the site where the stricture and the discontinuation of the duct was there. So we could reach up to the head side, and the entire pseudocyst was also drained from this ductal system. So the cyst was connecting with the pancreatic duct from the posterior side. So again, we usually place lots of stay sutures at the cut margin as usual, which we have been taught by Dr. Anish. And uh, so the duct was open from the head to the entire tail side. Once this is done, the next job is to connect with the jejunum, ruin wildlife of the jejunum. So yeah, here is the trick that if you take some stitch at the site of ductal and the pseudocyst opening into that, that will also be continuously draining into the ruin while loop of jejunum. So that will not cicatrize. Otherwise, there is a possibility that patient might have a persistent pseudocyst even after drainage. So the some wall of the pseudocystal opening is being incorporated into the this LPJ part, and then same the side to side LPJ first some stay sutures, and then in a continuous manner, the LPJ was done. This patient had lost almost 25 kg of weight before coming to us. Fortunately, after the surgery, this has been done around 6 months back. Now he has recovered, gained almost 16 kg of weight, free of all pleural effusion. Just for the sake of academic interest, we did a CT to see how his pseudocyst is there and anything is there. Almost complete resolution with almost 1 centimeter cavity is there, but he's all free of symptoms. So that's all. This is the simple JJ. So DPDS is again, we don't see much commonly at our center, but once it is there, managing in a way where you can preserve the pancreas gives the patient a long-term free of pancreatic enzyme and a better weight gain. That's all from my side. Thank you.
Thank you, sir, for a nice presentation, and you have highlighted the importance of we should know how to read the radiology. Because otherwise, it was a misinterpretation was suffered a lot because it does misinterpretation.
Yeah, so that was something important because it was like recurrent acute pancreatitis with management of acute pancreatitis line, but it was actually a disconnected syndrome and therefore it requires a surgical management. Because these patients will always have a high amylase lipase also, because this pleural fluid will have a high amylase content that also leads to high amylase lipase always. But they are not because of the acute pancreatitis per se, it is because of the collections.
So was this real disconnected syndrome? Because the most of the ducts was connecting into the duodenum.
No, sir. Only the head part was connecting to the duodenum. The entire neck, body, and tail was connecting to the cyst only. Yeah, that was seen in the CT also and MR also. Yeah. Thank you.
Now we call our speaker, Dr. Piyush Vasan, Associate Professor, Department of Obesity, Dean's to
Again, thank you to SGPGI and Anu ma'am for this opportunity. I'm going to present our routine right hepatectomy, but this time we did with the vessel sealer. So it was a 70-year-old gentleman on CT scan was found to have a multifocal SCC. There were 2 lesions, one in segment 6 and one in segment 8. This was the port position. And the falciform ligament is being taken down and the hepatic vein ostium is being dissected, the right hepatic vein. Divide the right triangular ligament as well, as much as we can divide from the top side. This is the right hepatic vein, you can see. Next, the tumor was adherent to the parietes. So a little bit of parietes was taken with the tumor. You can see the tumor bleeding when we are separating from the parietal wall. And a little bit of peritoneum was taken with the tumor while mobilizing it. Next is to mobilize the IVC. You can see the short hepatic veins that are draining into the segment 6 and the caudate. They are being clipped and divided. Cholecystectomy is being done routinely. And next, to loop the inflow structures, a retroportal lymph node is being dissected off to have a better access to the right portal vein. This is a small caudate branch that usually we find from the right portal vein is being divided, and the right portal vein is being looped with the blue vessel sling, and similarly the right hepatic artery is being looped with the red vessel sling. Temporary bulldog clamps are being applied to get a ischemic transition line. As you can see, there was a clear demarcation as we have a liberty of using firefly mode in robotics. So we gave ICG to have a better delineation. You can see a clear demarcation of a ischemic line on ICG. So ischemic line was marked from the right hepatic vein ostium till the inferior border of the liver. And then gallbladder was divided and the ischemic line was continued from the Canties line to the hilum. So next, the inflow is divided as we are not doing a donor hepatectomy, so inflow can be safely divided, and the selective Pringle can be obtained by dividing the inflow, and the right portal vein is also divided. After this, rest of the liver is mobilized. Keva, you can see the Keva is very squeezed off. The CVP was very low at this time as we were start parenchymal transaction. As much as Keva that can be mobilized was mobilized. All the short hepatic ones were similarly, like we do in open, the traction sutures were taken and they were pulled out using a suture passer. The full rubber band slings are being used. Next, we use this vessel sealer. So this is a fully articulating instrument that we found in exercise system. Unlike robotic harmonic, it has it can fully articulate. And it is a single use instrument. So combination of a vessel sealer and bipolar was used for the parenchymal transaction. So similarly, the segment 5 and segment 8 veins were divided. So this is the segment 5 tributaries of MHV. So that was divided. This is segment 5 vein. This is being looped and clipped. Parenchymal transition was progressed onto the cranial direction. And the segment 8 veins were also divided in the similar fashion. Advantage of laparoscopy or pneumoperitoneum is that bleeding is a lot less because of the pneumoperitoneum. So you can see a hole in the vein still, there was very minimal bleeding. So next was the division of the hilum. So we were able to loop the right posterior system and it was divided. While looping the right anterior system, there was inadvertent injury to the right system. So it was divided sharply, preserving the left duct. So this is the right anterior system is being divided. It was divided towards the right side because it's a non-hilum malignancy. So preserving the left duct was utmost priority. Next, the remaining parenchyma was divided and the right hepatic vein you can see was divided using vascular staplers. After right hepatic vein division, the small remnant part of the liver that was attached to the parietes was mobilized, and then the liver was put down into the fenestrine, and the right anterior system is being closed with PDS 5 sutures. Last thing was to hitch the liver again to the parietes. The falciform ligament, as only the left lobe, so it can topple. So it's usually practiced to hitch it back to the parietes. So this was again hitched to the parietes. Drain were placed in the Morrison's cavity, and the patient had a fairly stable post-operative course. This was the specimen, and patient is doing well. Thank you.
Thank you, sir, for a nice video demonstration. So, how many total lesions were there in this?
Two.
Two lesions. So, what is your post-op approach about adjuvant treatment?
Usually, they don't require any adjuvant treatment if R0 resection is there, as what the guidelines say. Only surveillance, 6-month ultrasound and MRI yearly.
So
AFP, accompanied by AFP. Yes.
So how you find a vessel sealer?
So actually, vessel sealer is bulky. Actually, vessel sealer is bulky, sir.
Yeah.
But the advantage that it's fully articulating. Now the newer generations of vessel sealer are slightly slimmer and more, ergonomically better. So I think it will be soon launched. They are calling it a synchro seal. So synchro seal, it is the newer version of vessel sealer. So it is much better than that.
So you use a ICG.
Yeah.
That is if you to find a right and left duct is absolutely okay. But when you use for the surface,
Yeah.
at that point of time, when you have dissected, it is very difficult to identify the bile leak. And when you do a vessel sealing and you had a right duct opening was there. So did you use that to cannulate and do some bile leak test?
No, sir. Actually, it was there. The right anterior ductal opening was there. That was deliberately made, so it was closed with suture. Only gauge test was done. No ICG or a probing was done, sir.
Yeah, because that you had a opening was there.
Yeah, that was
And
closed.
when you have used the vessel sealer, it is a slightly a crude method,
Sir,
Sometimes there may be a post-operative bile leak can happen.
yeah, I agree, sir. But the duct was divided sharply with scissor.
And sometimes what happens, it is ischemic tissue is slumped out and then you have bile leak post-operative.
Very true, sir. But I think the duct was divided with scissors this time. And for the parenchymal bile leaks, what we have seen is the percentage or the incidence of bile leak is similar as we do with harmonic or CUSA as we do with vessel sealer. Like we have done around 15 to 20 cases now. We don't find the increased incidence of bile leak with that.
Thank you very much.
Thank you, sir.
Appeal would be the best when you using the vessels in the combination of the two.
So that will be the end of this session. I'm handing over to Ankit Entry.
Thank you, chairpersons and presenters. This brings us to the concluding session of the 25th SG week. And for the same, I would like to invite Anu Madam on the stage for valedictory function.
Thank you.